Just message him. He will get back. I don't know whether he's
All right.
disabled. Yeah. No, I don't think he's joining. He said he won't be able to. Just
Okay,
What
in
about
between,
Suvarna
if
madam?
he
Has
can, he
anybody
finds a
reached out to
time,
her?
he can join. Yeah.
Yeah.
Otherwise, Swarna madam, Swarna Katilkar, is she joining?
Has somebody spoken to her?
I spoke
If
to
not,
her
then
in
I'll
the
speak to
morning.
her.
She said she will join. Nilima, is she in the office?
Yeah, madam is in office. She will join immediately.
Okay.
Okay, then we will start.
Dr. Ramani ma'am, you can go ahead.
Yeah. Good evening, everyone. On behalf of ICOG, I am very glad to invite all of you for this very, very important topic of endometriosis ICOG certificate course, which has been done for almost for the past 4 or 5 years. I think this is a very, very important topic, and especially the forthcoming month, that is the month of March, is an endometriosis awareness, and disease is increasing exponentially, and at the same time, there are so many changes, paradigm shift in diagnosis and medical management, surgical management, and fertility management. So this becomes a very, very important topic. And on behalf of the ICOG, I am very glad to welcome all the faculties as well as the participants who are going to join this program. Now, I request the coordinator to brief into the today's program. First, before that, we will start with the prayer song. That is. Okay, then the brief introduction of our President Bhaskar Pal. Can you show? Yeah. He is our current President of FOGSI, Senior Consultant at Apollo Multispeciality Hospital, Kolkata. And he was the Chair Endoscopy Committee of SAFA, Chair AACC, RCOG, Immediate Past President of IAGE, FOGSI Representative to SAFA 21 and 23, Chair Organizing Committee of AACOG 23, Kolkata, Past President of Bengal OBGYN Society, Vice President FOGSI in 2017, and an examiner for MRCOG Part 2, and authored so many papers and book chapters. But I think he is held up. So whenever he joins, let us have the blessings from him. Okay. Next, I welcome the ICOG current chairperson, Dr. Sheila Mane Madam, who is the past Vice President of FOGSI in 2014, Chairperson Safe Motherhood Committee, President BSO.
Yeah, enough. It is our program, Dr. Ramani. Okay. And
I welcome Dr. Sheila Mane to address the gathering.
Dear friends, I really feel privileged, and I have a proud moment for me to start our first certification course program today of this year 2026. Okay. And thank you, Dr. Bhaskar Pal, for allowing us for all these activities. And in his absence also, I would like to welcome him for this certification course. Now, I thank Dr. Ramani, who is the convener, and for this endometriosis program. We know all the expertise are here. We have Dr. Anu Chawla, we have Dr. Kanti, we have Dr. Asha Rao, who have been working for this earlier, and they still continue to work, and I know the passion. So I'm sure that this 3 days certificate course is all inclusive about endometriosis. We thought of doing this because it wasn't done earlier. And all of us, we know that day by day we see more and more cases. And it is very important because to diagnose it early and manage it properly. Because fertility preservation becomes a very important part of the management, as we are seeing endometriosis affecting young girls, even we are seeing the endometriosis. So if there are any youngsters, I think the history taking also will be covered, but we have a classification, but it is very, very important. Anybody coming to you with severe dysmenorrhea, chronic pelvic pain, and long-standing infertility, all these are the factors which will make you think that this patient may be suffering. So proper diagnosis and management plays a very, very important role, and we have to be vigilant about this. And I'm sure all the faculty whom we have chosen and who are going to speak in these 3 days will do the justice, and all of us will be really overwhelmed with that. I'm sure all that. So once again, on behalf of ICOG, myself and Dr. Pratik Tambe, my secretary, we welcome you for this program, and I'm sure it will help you a lot. Okay, thank you.
Thank you, Dr. Sheila, for your kind words. And I next request Dr. Swarna Katilkar, the Secretary General of FOGSI. She has been the professor and head of the Department of OBGYN, Endocrinologist and Gynecologist of Bombay Hospital. Secretary General of FOGSI
Ramani,
2025.
Ramani, it's okay.
Yeah.
Don't introduce. I have
Okay,
another
okay. I welcome
meeting.
Dr. Swarna on behalf of ICOG to say a few words and give us the blessings.
Thank you so much. It's not blessings. It's just that on behalf of FOGSI and ICOG, I would like to welcome everybody. Sheila has already welcomed, but as Dr. Bhaskar, I don't think he has come so far. I'd like to welcome everybody, and I see the program on endometriosis certification course, and I think it's the first certification course that during Sheila's tenure. So I think whatever begins well will also end well. So I'm sure all these stalwarts of endometriosis who have joined here today, I'm sure they will do justice to this whole certification course, because when you just say a webinar, it's different. When you say certification course, it is, I'm seeing the 3-day detailed program, and it really means like the every detail about endometriosis, all the aspects of the diagnosis, the symptoms, the various therapeutic modalities, everything in minute has been covered. And I'm sure even those young postgraduates who have finished their post-graduation will learn a lot. And I congratulate Sheila, Dr. Ashok Kumar, Dr. Sadhana Gupta, Dr. the Pratik Tambe. I thank myself also, Dr. Ramani Devi, who is the convener. Ramani, you are doing a great job. I think we met at the endometriosis consensus also. So Dr. Asha Rao and Dr. Kanti Bansal, who are the first day coordinators, and I am sure these two people are going to wonderfully conduct this program. And I see Lakshmi, I can see Dr. Hitesh Chauhan, who is also with me in the other meeting, which I'm going to soon start. Chinmay, Asha, everybody, Anu Chawla, who's the endometriosis chair, and Sheila, Shobha, Sneha, I can see so many, Suchita. Oh, good to see so many of my friends. So I wish you all the very best. And I'm sure, this is going to be a great learning experience for all of those, the juniors as well as the seniors. And I'm sure when you start teaching something, you learn a lot. You learn so many newer things, newer nuances about each topic. So I think teaching is the best way of learning. That is what I've realized after having been in teaching profession for last more than 35 years. So please continue these certificate courses. I'm sure everybody will be benefited with this course. Thank you so much. I'll take your leave. I have to join another meeting. Thank you. Thank you so much.
Thank you, Dr. Swarna, for your kind words. Next, I call upon Dr. Anu Chawla, who is the chair of Endometriosis Committee of FOGSI, to share her views and give few words of wisdom today.
My deep thanks to ICOG Chair, Dr. Sheila Mane, who I really respect from the bottom of my heart, and all the learned colleagues, Dr. Pratik Tambe, Dr. Suvarna Khadilkar, Dr. Bhaskar Pal, Dr. Ramni Devi, who's organized everything, and all the learned colleagues. I want to take a minute to speak about what just happened 2 days back. So in BAFTA, the film that got awarded was called This is Endometriosis. So this is the title of the film. But what really has been awarded was validation. I would say, when endometriosis was spoken about on a global stage, something shifted. For decades, women with endometriosis have been told your scans are normal, painful periods are common, maybe it's stress, it's probably in your head. And let me say this clearly, the pain is real, it's not in their mind, it is in their pelvis. Endometriosis is not just about periods. We know it's inflammation, DIE, infertility, fatigue, missed work, strained relationships, silent suffering, and it can be disabling. So it is a lot going on. And what moved me the most was not just the visibility, it was the naming of the medical gaslighting. As doctors, we must reflect. Are we listening enough to the patients? Are we dismissing symptoms because imaging is normal? Are we trained adequately to recognize the deep disease? Are we referring early enough? Because the average delay in diagnosis, even in UK, is 8 years, but it can be still almost a lifetime in some developing countries. That delay is not biology, it is a systemic failure. Visibility matters, but action matters more. So we need early diagnosis, better ultrasound training, multidisciplinary care, fertility preservation counseling, proper research funding, and above all, the belief. To every woman living with endometriosis, I would say you're not weak, you're not exaggerating, or you're not imagining it. Your experience is real, and as clinicians, we must do better. So thank you very much, and best of luck for the course.
Thank you, Anu, for your kind words and then insight regarding the endometriosis. And next, I call upon the coordinators, Dr. Asha Rao and Dr. Kanti Panchal. Can you throw the Dr. Ashok Kumar?
I think he has not
Was-
joined.
You
He
can
is
just
not there.
mention the ICOG office bearers in passing. Dr. Ashok Kumar will be here
Yeah, he was
tomorrow
the
on
past
day 2.
secretary for ICOG, and I
Dr.
welcome
Sarna
him.
Gupta and Dr. Ashok Kumar will be there to grace the occasion tomorrow during the inauguration. And on the
Okay.
third day, it will be myself and Dr.
Okay.
Sarita Malika.
Okay. So today, I request now the coordinators to take over. Just as an overview of we have divided the topics into for 3 days, day 1, day 2, and day 3. And day 1, we will be having about the overview of endometriosis by Dr. Lakshmi Srikante. Then the next will be adolescent endometriosis, which has to be given so much of importance by Dr. Sampath Kumari, and then imaging modalities by Archana Baser, and non-invasive diagnosis that is going to come up in a very big way, because no more the diagnosis of endometriosis is made through laparoscopy or histopathology, but it is going to be based on non-invasive diagnosis. Then there are a lot of changing trends in medical management. There is definitely a paradigm shift in everything, starting from etiopathogenesis up to the ART. Then endometriosis, initially we say that it's very common during the reproductive age group, but now we know that it starts in womb and ends in tomb. That is, even it can start in the adolescent young girls and continue to grow up in the perimenopausal woman. And then for this, we need to have create awareness among the public as well as the doctors, because I came across a article where they had given one questionnaire to the consultants and specialists in OBGYN. It was very sad to know only 40 to 50% of these general practitioners knew about endometriosis symptoms. So that means we need to create awareness among our professional as well as the public. And then as a result of this disease, there is a lot of stress the woman becomes very much depressed, and that will be spoken by one of our faculties. And finally, we have a panel discussion on endometriosis in associated infertility that will be moderated by Dr. Mala and Asha Bakshi, and the experts will be Dr. Kunjumaidin and Sundar. And a lot of learned faculties are there, and I'm sure today's program will give you an overview about the endometriosis. Then following that, every day we have a post test, that is an MCQ, which will be sent in the link. You can open up and answer, and there will be 20 questions in each day, and at least we must get 50% of marks on each day, so that you get you should have attended all 3 days and certificate from ICOG. So with this, I hand over to the coordinators, Dr. Kanti Bansal and Dr. Asha Rao. Dr. Kanti Bansal is Director of Safal Fertility Foundation.
You don't have to.
And she is the first endometriosis committee chair. And Asha Rao madam is the past endometriosis committee chair. So both of them, I hand over the scientific session to both of them. Go ahead.
Thank you, Ramani, and thank you, Dr. Sheila, for having given me this opportunity to be here as the convener. And it's such a fantastic gesture that endometriosis has been taken up as the first certification course for the year. And endometriosis is really increasing in numbers, and there is a real necessity to educate the public as well as the young doctors and the senior doctors also, because the trend has been changing over the last decade. So non-invasive diagnosis and non-invasive management has to be discussed with the colleagues. And now that I'm going to the airport, I request Dr. Kanti Bansal to take over as the coordinator. Apologies for that.
Yeah, so
you log in on and off in between, Kanti. Thank you.
Yeah, thank you. So I'm very, very happy that my friend Dr. Ramani Devi has started this, ICOG certificate course. It's the need of the hour, and endometriosis is such a subject that how much ever we teach, how much ever we learn, it seems to be, not approachable. And I would not take too much of time, and I would go ahead with inviting Dr. Prateek Tambi, who is our ICOG secretary. I must say the most hardworking secretary. He's from Mumbai, and IVF consultant.
No need to formally introduce me, ma'am. We're fine. Let's get ahead.
Okay.
Let's go ahead.
Yeah, so Professor Bharti Maheshwari, she's the professor and head of Department of OBGY and IVF, Muzaffar Nagar Medical College. And she's
one-line introduction for all.
Dr. Sneha, she's practicing OBGYN with 32 years of experience in the field. Next. Chinmay Rathe, she's the president of Telangana chapter, and also received the Dr. Mehru Dara Hansuti Award for Best FOGSI Committee.
Thank you, ma'am. Pleasure to be here.
Yes.
Thank you very much, Dr. Ramani Devi, Dr. Kanti Bansal, Dr. Asha Rao, and of course, gratitude to our ICOG chairperson, Dr. Sheila Mane, for taking up this 3-day mammoth task of the ICOG certificate course on endometriosis. As you've heard, it is very much topical. Without further ado, I would like to introduce the first speaker of the day, who is none other than Dr. Lakshmi Srikhande. She is a past chairperson of our ICOG. Currently, she is the FOGSI representative to AOFOG, and she is part of the FIGO committee on climate change. May I present to you Dr. Lakshmi Srikhande, who will present a brief overview of endometriosis.
Thank you. Thank you so much, Prateek, for that kind introduction. I hope my slides are visible and I am audible.
Absolutely fine. Please go ahead.
Just a minute. And a very good evening to one and all. And I'm happy to be the opening batsman for the first certificate course of this tenure. And the topic given to me is overview of endometriosis. Friends, we all know endometriosis is a chronic inflammatory disease defined as the presence of endometrial-like tissue outside the uterus. Establishment and growth of such endometriotic tissue is estrogen dependent, and it is mostly found in women of reproductive age, although the clinical consequences of endometriosis and its management can last well into postmenopause. The exact prevalence of endometriosis is unknown. Just a minute, all these things are coming in my way. I will just minimize. Yeah, the exact prevalence of endometriosis is unknown, but estimates range from 2 to 10% within the general female population, but up to 50% in infertile women. It is estimated that at least 190 million women and adolescent girls are affected by the disease worldwide during reproductive age, although some women may suffer beyond menopause as well. While not all women with endometriosis are symptomatic, endometriosis associated pain and infertility are the clinical hallmarks of the disease, affecting not only women with endometriosis but also their partners and families. Impact of endometriosis, particularly the pain symptom, has been shown on the quality of life but also on the range of activities and life domains, including the physical functioning, everyday activities, social life, education and work, sex life, intimacy, and intimate partnerships, also the mental health and emotional well-being. So, as a clinician, we all should consider the diagnosis of endometriosis in any woman presenting with the following cyclical and also non-cyclical signs and symptoms when they come to you with dysmenorrhea, deep dyspareunia, dysuria, dysgeusia. So, this list we all should remember. Clinical examination, including vaginal examination, where appropriate, should be considered to identify the deep nodules or endometriosis in patients with suspected endometriosis, although this examination accuracy is low. In women who are suspected candidates for endometriosis, you need to go ahead and offer imaging to these women. ICOG guidelines tells us that the measurement of biomarkers in endometrial tissue, blood, menstrual or uterine fluid should not be done as a diagnostic tool for endometriosis. However, clinicians are definitely recommended to offer ultrasound and MRI in selected cases. What is the role of laparoscopy? Historically, the laparoscopy used to be the gold standard and the histological tissue diagnosis when we are doing laparoscopy. But the current guidelines tells us that you have to reserve diagnostic laparoscopy for those women with persistent symptoms despite medical therapy, when imaging is inconclusive, or when surgery is planned for pain or infertility. And if you are planning to do laparoscopy, your aim should be to diagnose and operate in the same sitting. It should be done by an experienced team with multidisciplinary backup for bowel, urethral, and urinary tract involvement. So, what is the treatment when she comes to you with endometriosis pain? Of course, the first line is NSAID. You can combine this with COCs in the form of oral tablets, vaginal ring, or transdermal patches to reduce the dyspareunia, dysmenorrhea, and non-menstrual pain. When you are giving the oral pills, the continuous use of COC is recommended as compared to the withdrawal bleeds each cycle. You can also offer them progesterone if there is contraindication to estrogen. We can safely give them LNG-IUS or an etonogestrel releasing subdermal implant to reduce this pain. When you are considering the progesterone, you have to take into account the side effects and the different profiles of different progestrogens. Danazol and antiprogestrogens, laparoscopic uterosacral nerve ablation, presacral neurectomy, and anti-adhesion agents are no longer included as a part of ICHRE guidelines for endometriosis. Now we have GnRH agonist as a second line. Do consider the ADVEC therapy to reduce its adverse effect on bone mineral density. Now we also have oral antagonist which is available and which is approved by DGCI for this indication. So in nutshell, when it comes to medical management, NSAID plus trial of hormone therapy, progestins, second line agonist and antagonist, You can give GnRH antagonists. They have proved their safety, their efficacy. You have to tailor the patient desire for fertility, comorbidities, side effects, and tolerance. And for adolescents, you can prefer LNG, IUS, or progestins where appropriate. When it comes to treating the refractory pain, aromatase inhibitors may be prescribed in combination with oral contraceptives, progestogens, GnRH agonist, or GnRH antagonist to treat this refractory pain. When you should consider the surgery, it can be one of the options to reduce the pain. As I already said, you have to perform excision instead of ablation, perform cystectomy instead of drainage and coagulation if you are operating on endometrioma, but you have to caution the woman about the decreased ovarian reserve if you are going for cystectomy. The guideline recommends that women with deep endometriosis, they should be referred to a center of expertise. Can you offer them hysterectomy for endometriosis associated pain? Yes, in those women who no longer wish to conceive and who fail to respond to your conservative treatments, but you have to inform them about the side effects of this and you have to take them into confidence for postmenopausal hormone therapy. Guidelines are not recommending the preoperative hormone treatment, but postoperative hormone treatment can be offered to those women who don't want to conceive immediately after the surgery. So what you should do, whether you should offer them medical treatment or surgical treatment, it has to be a shared decision making between you and the woman, and you have to take into account the individual preferences, side effects, individual efficacy, cost, and availability into consideration. When it comes to adolescence, the ICOG emphasizes early recognition and trial of medical therapy to reduce the delay in diagnosis and to address the impact of endometriosis on school attendance and also to take into account the psychosocial impact. When it comes to infertility, the extended administration of GnRH agonists prior to ART is no longer recommended. The endometriosis fertility index has been added as a step in the treatment as it can support decision making for the most appropriate option to achieve pregnancy after surgery. Operative laparoscopy could be offered as a treatment option for ASRM stage 1 and 2 endometriosis as it improves the rate of ongoing pregnancy. However, one should not forget to evaluate the male partner when you are treating the endometriosis associated infertility. What about ART in these case scenarios? The routine surgery for endometrioma is not recommended. However, if you are finding it difficult to assess the follicles, then only you are justified in offering them the surgery for endometrioma. ART can be performed in endometriosis, especially if tubal function is compromised or there is male factor infertility in case of low EFR and or if other treatments have failed. A specific protocol for ART in endometriosis has not been recommended by the ISHRE. Both antagonist and agonist protocols can be offered based on your preferences. Women should be reassured regarding the safety of ART since the recurrence rates are not increased and you can consider giving her antibiotic prophylaxis at the time of oocyte retrieval. What about its impact on pregnancy and pregnancy outcome? Patients should not be advised to become pregnant with the sole purpose of treating endometriosis as pregnancy does not always lead to improvement of symptoms or reduction of disease progression. It may change its appearance during pregnancy and there may be a slight increased risk of first trimester miscarriage and ectopic pregnancy. What about endometriosis and menopause? You should be aware that endometriosis can still be active or symptomatic after menopause. You should acknowledge the uncertainty toward the risk of malignancy in postmenopausal women. If a pelvic mass is detected in menopausal women, the workup and treatment should be performed according to the National Oncology Guidelines. And for postmenopausal women, aromatase inhibitors can be considered as a treatment option, especially if surgery is not feasible if she has come to you with the pain symptom. What about the recurrence? Prevention is better than cure. Surgery should be performed by an experienced surgeon. Surgery should be complete. You should perform cystectomy instead of drainage and electrocoagulation, and post-op use of LNG IUS or combined CSE for at least 18 to 24 months should be given to prevent the chances of recurrence. Can endometriosis lead to cancer? It is not associated with a significantly higher risk of overall cancer, although it is associated with a higher risk of ovarian, breast, and thyroid cancers in particular. The increase in absolute risk compared with women in the general population is low. Complete excision of visible endometriosis may reduce the risk of ovarian cancer, and the potential benefit should be weighed against the risk of surgery, that is in terms of morbidity, pain, and ovarian reserve. So friends, endometriosis, when you are managing, it has to be a multidisciplinary team. You have to work in the chronic pain model, involve the pain specialists, physiotherapists, CBT, psychology, gastroenterology, urology when indicated, and monitor bone health with prolonged hypoestrogenic therapies when you are giving GnRH agonist. What about the follow-up? The follow-up and psychological support should be considered in these women who have confirmed endometriosis. The appropriate frequency and type of follow-up or monitoring is unknown, and it should be individualized based on previous and current treatments and the severity of the disease and symptoms. Consider quality of life and mental health screening in your follow-up visits. Can it be prevented? Healthy lifestyle has been recommended as a general recommendation, and the usefulness of hormonal contraceptives for the primary prevention of endometriosis is uncertain. So the take-home message is endometriosis is common, heterogeneous, often underdiagnosed. You have to use targeted transvaginal ultrasound, MRI to map the disease before surgical planning. First line medical therapy is NSAID plus hormones, that is COCs or progestins. You have to reserve surgery for specific indication, and you have to ensure that it is done by the experienced surgeon. Now we have oral GnRH antagonists in our armamentarium, which has expanded our horizon to treat these women. Multidisciplinary care improves the outcomes, addresses fertility, pain, and mental health. My whole talk is based on the latest ISHRE guideline, NICE guideline, and ICOG guidelines. Friends, there still exists a large diagnostic void between the onset of symptoms and a reliable diagnosis, which averages between 8 to 12 years. So diagnosis of endometriosis is still a big challenge. Remember, behind every delayed diagnosis is a woman who waited too long to be heard. Thank you. I am grateful for the support, mentorship, and confidence reposed in me throughout my journey, and I humbly seek your blessings and continued support as I strive to contribute meaningfully to FOGSI and the cause of women's health in the years ahead. Friends, as a FOGSI representative to AOFOG, I invite you all for this AOFOG conference, which will be held in Sydney from 12 to 15 October 2026. We have formed a group and we want to take a big FOGSI delegation. We want to represent in a big number to this conference. And I also invite you to this FIGO conference, which will be from 31st October to 5th November 2027 in the capacity of FIGO committee member. So let's come forward and go there in big numbers. Thank you. Thank you so much once again for patient hearing. And thank you, Sheila, Pratik, and team ICOG for having me as the opening batsman for your first certificate course. Thank you.
Thank you, Lakshmi.
Thank you very much, Dr. Lakshmi Shikhande, for keeping to time and a brilliant overview. I'm very pleased to announce that we have nearly 600 delegates already logged in, and total number of registrations for the certificate course has exceeded 1,200. So we will see more and more numbers as the day goes by. Without further ado, we would like to invite the next speaker. And can I request Dr. Sneha Bhoyar, if she is there, or Dr. Chinmay, to please introduce the next speaker.
Thank you, Pratik sir. And at the outset, I thank Ramani Madam and Sheila Madam for this opportunity to be part of this very, very exciting program. And it's nice to see so many people logged in. The next speaker is none other than Professor Sampath Kumari Ma'am. And all of us know her as one of the champions of adolescent health in FOGSI. And she has taken the concept of adolescent health way beyond what we had imagined in common parlance. And in this program where we are discussing endometriosis, it is only very apt that she will be discussing the adolescent endometriosis with a very interesting top heading called the hidden lesion. So the multiple problems that are associated with adolescent endometriosis, we will be waiting to hear from Sampath Kumari ma'am. She is not new to FOGSI and she is looking for some major roles in FOGSI. So I'm sure she will do a great job with this topic. Thank you very much, ma'am. Welcome to the podium.
I can see her logged in, but her video is off.
Sampath ma'am, can you hear us?
In case she's away from the desk,
yeah.
we can proceed
Otherwise,
with the
we can,
next speaker.
Sneha ma'am, you can introduce the next speaker. I'll call Sampath ma'am and check.
Yeah, Dr. Archana Basil is the next speaker. I see her logged in as well.
Can we have the CV, please? A very good evening to all of you. And at the outset, I would like to thank the entire ICOG team for having us here. And this is the fantastic certification course. I'm very happy and like to congratulate the team for the great attendance. Dr. Archana Basil, our next speaker for the non-invasive diagnosis of the endometriosis. I'm sure all of you know her so well. She is holding the positions, she has held many positions in FOGSI as Vice President FOGSI 2022, Chairperson of ISAR 25 to 27, MP ISAR, and of course, she's the fellow representative of AICC RCOG West Zone. She's lots and lots of positions in the past also. So without much ado, I would like to hand over the mic to you, Dr. Archana, and we are eager to listen to you.
Welcome, Archana. Can I be allowed to share my screen, please?
Yes, ma'am. Please go ahead.
Yes, you can see. Just make it full screen.
Is it visible?
Yes, ma'am. Please go ahead.
A very good evening to all of you. And at the outset, let me thank Dr. Pratik Tambe, my dear friend Dr. Ramani, Dr. Sheila Mane, Dr. Sneha, Kanti, all for giving me an opportunity here to talk about endometriosis in ICOG masterclass. So what I'm going to be taking is imaging in endometriosis. And imaging in endometriosis, as I think we have heard our previous speakers and Dr. Anu as well, that imaging is very, very important in endometriosis. And all of us know endometriosis is a costly chronic disease. And nearly 10% of women of reproductive age group suffers from endometriosis. And if you want to know about the facts and figures of endometriosis, 1 in 10 women have endometriosis, and it takes an average of 7 years for most women to get diagnosed endometriosis. And mind it, it is the second most common gynecological condition after the fibroids. So just an overview of what I'm going to be talking in my talk. Definition of endometriosis, I'm not going to dwell much into it. Ultrasound appearance of endometriosis, which is my topic, which I'm going to be really focusing on. And the most important thing, I'm going to be taking you through how to assess for the pelvic mobility and what to look for during an endometriosis scan. So just endometriosis is a presence of endometrial-like tissue outside the uterus, which includes a chronic inflammatory reaction. Endometrium, what we can pick up by ultrasound is endometriomas, adhesions, and endometriotic nodules, which can be deep or superficial. Now, the diagnostic modalities with us, number one is the clinical by history. Second is by ultrasound, contrast ultrasound, MRI, CT, endoscopy, biochemical screening, and histopathological definitive diagnosis. So let's straight away go on to the ultrasound. Ultrasound is the most preferred modality for assessment of pelvic pathology. And how you can do ultrasound? Number one is by the transvaginal ultrasound, transabdominal, and transrectal. I always say whenever you are taking a woman with the pelvic pain, you may be howsoever proficient in transvaginal scan, but do put a transabdominal scan, and especially in endometriosis, look at the kidneys and the ureters as well. So ultrasound, why ultrasound? Because it is widely available, cost effective. Ultrasound can pick up ovarian lesions, endometrioma. It can pick up deep invasive endometriosis. Now the scanning technique, it should ideally begin with survey of whole abdomen with 3.5 megahertz probe and follow it with transvaginal scan. We should have a partially full bladder, so bladder can also be evaluated. Grayscale imaging can be improved by using HI, CRI with the even subtle textural changes associated with endometriosis, which can be appreciated. And 3D volume may be used to assess multi-organ involvement. Now, these are the surgical staging of endometriosis. I need not go into detail of it because there are other lectures which will be taking it into detail, but we can have minimal disease, mild disease, moderate disease, and severe disease. So stage 1, 2, 3, and 4. So that is how you do the staging. Whenever we are doing the laparoscopy, we have this pictorial diagram in our file where we draw whether it is a minimal endometriosis, moderate or severe endometriosis, and whatever classification you want to use, you can use ASRM classification, or you can use other classifications as well. Now, for purpose of this lecture, I will be describing how to identify structures involved by endometriosis and showing corresponding laparoscopic images to improve the correlation. And this can then be staged by any classification system you are comfortable with. So let's go step by step. So what are the structures involved in endometriosis? Ovaries, uterosacral ligament and POD, bowel, rectum, bladder, and uterus. So let's look at the ovaries first. By the ultrasound, ovarian endometriomas are probably the most commonly diagnosed form of endometriosis because of relative ease and accuracy of ultrasound diagnosis. Although their exact prevalence and incidence are not known, they are reported in 17 to 44% of women with endometriosis. The presence of ovarian endometriosis has been reported as a mark of deep endometriosis and multifocal deep vaginal, intestinal, and ureteric lesions. So ovarian endometriomas are common, can mimic other adnexal masses. Endometriomas result from cyclical hemorrhage. The walls are thick and fibrotic. The contents consist of thick, dark, degenerated blood products, also known as chocolate cysts. If unilateral, they are more likely to occur within the left ovary, and if they are bilateral in approximately 50% of cases, and usually endometrioma regress substantially after menopause. So these are the typical features of endometriomas. Fluid level, the hyperechoic layer will be dependent portion of the cyst. It can have calcified foci within the cyst, that is acoustic shadowing. There can be a typical avascular or low flow. Acoustic streaming can help discriminate from mucinous and serous cyst adenomas. So this is again a ovarian endometrioma. You look here, there's a very minimal vascularity and there is a ground glass appearance. Now, the important thing is endometriosis may not always look the same. Notice the cholesterol deposit in this clear looking cyst. Look here, this does look like a clear. You may confuse that it is just a clear cyst, but look at the cholesterol deposits here. Now, ovaries seen stuck behind uterus in this picture. So this is the image of the same patient, which we have seen before, showing the ovaries stuck behind the uterus. Those of you who are doing ultrasound would know that whenever you are taking a sagittal section, ovaries should not be seen in the sagittal section. They are usually seen in the transverse section. If they are seen like this, it means they are stuck ovaries. And this is the laparoscopic view of the same patient. If you see that ovaries are stuck behind the uterus. Now, multiple ovarian endometriomas in the same ovary. So this is a picture where you have this endometrioma and these are the two other endometriomas. Why it is important to do the mapping of endometriomas before you are taking up or planning any further surgical intervention. Why? Because what will happen if you have multiple endometriomas and you have missed, you have just dealt the bigger one and the smaller ones are left, then there will be a recurrence. And you might say, well, this is a new thing. While if first surgery is the best surgery, so multiple endometrioma, it is important to avoid any residual endometriosis. And this is again an image showing multiple endometriomas in the same ovary. It is important this assessment is made prior to surgery. Again, endometriomas, ground appearance with the cholesterol deposits in it. And this is the laparoscopic picture of the same with the uterus and the endometriomas, and it is a stuck kind of a thing here. Again, the small endometriomas, they do not change. The beauty of diagnosis of endometriomas by ultrasound is because other cysts, they change their size during the menstrual cycle, while the endometriomas usually do not change their ecostructure during different phase of menstrual cycle. So this is again endometrioma. This was a large endometrioma, the picture on ultrasound and picture on the laparoscopy. Now this, I'm not putting the laparoscopy thing, like this is again a endometrioma, same endometrioma. Let's go into the next picture. Now, differential diagnosis of endometriomas, dermoid cyst, hemorrhagic cyst of ovary, serous cyst adenoma, and pseudocyst adenoma. So this is here is a typical dermoid cyst where you see hair follicles like the tuft of hair. That is a typical dermoid plug picture. But if you just look at here, the ground glass appearance looks pretty similar. So it is important that whenever you see a cyst, you really need to do a very good scan and find out what kind of a cyst it is. And this is a hemorrhagic ovarian cyst, which is a unilocular thin-walled cyst with fibrin strands or low-level echos. And this is a simple unilocular serous cyst adenoma. And this is a pseudocyst adenoma, usually seen as large multilocular cyst containing fluids of various viscosity. They rarely appear as unilocular cysts. So look at here. This is the sonography picture, and this is the laparoscopic picture of the same pseudocyst adenoma. Now, endometrioma rules. The single best discriminator between endometrioma and other cysts is a ground glass echogenicity, premenopausal status, 1 to 4 locules, and absence of papillations with detectable blood flow. They are rarely sole finding. It is important to identify other structures involved whenever you see endometriomas. This is a picture of the kissing ovaries, which is strongly associated with deep endometriosis. And look here, this is the severe endometriosis where there's a kissing ovaries, and that can very well be picked up on ultrasonography. And this is, now let's move on to uterus in endometriosis. We have looked at the ovaries. Due to involvement of the uterosacrals leading to adhesion, endometriosis tend to cause retroflexion and retroversion of the uterus, and this should alert us to possibility of involvement of POD and need for further assessment. This is a picture here. What you see here, that the uterus is retroverted and retroflexed. Let's see here in this clip. This is an altered version of uterus due to adhesion in POD. What you can say is a comma-shaped uterus because it is being stuck and the uterosacrals get shortened because of the endometriosis. Now, nodules or implants can also be seen. The only laparoscopy can detect superficial peritoneal implants. Bigger implants you can see on sonography. This is a nodule which can be seen here. This is a nodule which can be seen, and the white lines denotes the uterosacrals. So this is just a moderate endometriosis. Deep invasive endometriosis is something which I want to highlight here, that it can be picked up by ultrasonography. Its location can be rectosigmoid, uterosacral, vagina, and the bladder. So these are the different location of deep invasive endometriosis. You can pick up the bowel nodule. They involve anterior rectum, rectosigmoid, typically hyperechoic or isoechoic solid masses. They are tender on palpation. So look the picture here. This is the bladder, and this is the bladder endometriosis. When we are doing the another way, this is like full bladder. You can see the nodule into the bladder, and this is a bladder endometrioma which can be picked up. Why it is important to diagnose bladder endometriosis? Because it occurs in 1 to 4% of women with laparoscopic diagnosis of endometriosis, and the diagnosis is often delayed or not considered at all. And this is a case where this was delayed of my own delivered patient, whom I delivered 22 years back. She presented to me with the constantly problem of urinary tract infection, and she has dysuria she never was offered an ultrasound. When we did an ultrasound, transabdominal, her ureters were dilated, non-functioning kidney, leading to hydronephrosis, and then we had to do nephrectomy. That was a very sad thing for us to do. So my point is that you should pick up the endometriosis in time. Think of endometriosis in a young woman who is presenting to you with the pelvic pain. Not only do a transvaginal scan, but do a transabdominal scan also and look at the ureter when you're suspecting deep invasive endometriosis. Endometriosis can happen in myomectomy scar also. You have to look at the ovarian mobility by this, like this is a picture where I'm showing your ovarian mobility, that is called a sliding sign, which can be picked up. Just put a little pressure on the probe and you can see sliding sign. So sliding sign, positive sliding sign means there are free of adhesion, and if it is an absent sliding sign, when everything is moving together, that is a negative sliding sign. So follow the Blake line, identify the rectum, and that tells you that this is a sliding sign present. Then the adhesions can be picked up like flap signs. So this is the question mark sign of the fundus, and this is adhesion in the POD, thickened uterosacral. So checklist in endometriosis: uterus mobility and adenomyosis, ovaries, endometrioma and mobility, mobility of anterior compartment, mobility of posterior compartment, bladder, bowel, and hydronephrosis, that can all be picked up. And MRI, people say that yes, MRI is also one of the modality of imaging for endometriosis. I only offer it in the patient who have already had surgeries and we know that there is a deep invasive endometriosis, just to do the counseling and talk to the patient. And there is an internal terminology of endometriosis, IDA, which is a very good article, which if you want to go through it, it is a paper, have explained detailed analysis of endometriosis and ultrasound. So take home message: transvaginal ultrasound is accurate at assessing endometriosis. Assessment of pelvic mobility can indicate adhesion. So thank you very much for giving me an opportunity, and I seek your support. I'm walking together with you in the FOGSI. I'll be with you, for you, by your side, and I am FOGSI President candidate for election year 2026. Need your support and need your blessings. And I invite you to FOGSI Vice President Conference, which is in Indore from 8th, 9th, and 10th May. And it is one of the conference where all 5 vice president in the Dr. Bhaskar Pal's tenure are coming together and doing a conference in Indore. So please be part of it, and we welcome you all. Thank you very much. And if there is any question, since 30 minutes or 30 seconds are left, I'm happy to answer.
Thank you very much, Dr. Archana Basir. Fantastic lecture, amazing images and videos. Thank you for sharing them with us. I think when it comes to imaging and it comes to ultrasound, 3D ultrasound, we can think of no better faculty than you, specifically to talk about these obscure and difficult conditions. Can we move to the next speaker? I think Dr. Sampat Kumari was not
Ma'am is
available earlier.
connected.
Yes.
Yeah, you can have an
Yes, Pratik, I am there, but my video is not opening.
No worries, ma'am.
No worries. Right, I'll share my screen.
You can go ahead and share your screen. I'll send you a request to share your video. Let's see if that works.
No, it's not opening. Anyway, I'll share my screen.
All right.
Yes. Pratik, can you see my screen?
Yes, ma'am. You can go full screen, please.
Yes. Anyway. Thank you. I thank ICOG and Dr. Ramani Madam and Sheila Mane Madam, the chairperson of the ICOG, for giving me this opportunity. My talk is on endometriosis in adolescents. Yes, madam. Anything?
Make it full screen.
It's not full screen, ma'am.
Full screen only.
No.
Ma'am, I think just once you unshare and share again, because it's not coming full screen for us.
No, sometimes it's the old version of Office. Dr. Vidya Thobi also has the same issue quite frequently. That's all right, ma'am. Please go ahead.
Okay.
Let's not stand on ceremony.
Okay. Okay. So my topic is on adolescent endometriosis. Hope everyone would have told about that endometriosis, the previous speakers. The endometriosis is the presence of endometrial glands and stroma outside the endometrial cavity. Stroma is more than the glands in the adolescence. Endometriosis is an estrogen dependent and progesterone resistant chronic inflammatory condition. See why we are very much bothered about the endometriosis in adolescence. Most of the time with the dysmenorrhea pain, this endometriosis will be missed. The disease is often unrecognized, ignored, and mislabeled in adolescent populations. Though frequently it results with the pelvic pain, adhesive disease, and infertility. Sometimes this endometriosis in adolescents, they don't even have any symptoms. It is an atypical
Sorry to
presentation.
interrupt you, ma'am. Ma'am, your slide is not moving, ma'am.
Not moving.
Yes, ma'am.
1 minute. Is the endometriosis around me? Here. Now, can you see?
Yes, it's perfect now. Yeah.
Yes, ma'am.
Moving?
Yes, ma'am.
You change it,
Yes.
ma'am?
Yes. So the early
Yeah.
diagnosis and treatment may decrease the disease progressions and prevent the infertility. The prevalence, what is the prevalence in teenagers? Most of the time it is 5 to 10%, but most of the time it is not diagnosed. So the prevalence may be different. 25 to 50% of the girls with dysmenorrhea and atypical pain abdomen of chronic nature have this endometriosis. It is seen that 50 to 70% of the teenagers undergoing laparoscopy for any pain and dysmenorrhea, that time the endometriosis sometimes can be diagnosed. But we don't prefer the laparoscopy in the adolescents, and it is only the last mode. The prevalence may be even higher when laparoscopy is done by senior endoscopist. So what is the types of endometriosis in adolescents? Normally it is peritoneal endometriosis, ovarian endometriosis, deep infiltrating endometriosis. So you had that wonderful talk by our previous speaker also. What are all the risk factors in adolescent endometriosis? Any adolescent girl can have the endometriosis, but in spite of that, the risk factor is being the early age, the menarche, less than 12 years, and frequent and prolonged cycles. Girls with low BMI, normally with a high BMI means we think of PCOS, sometimes with a low BMI, we can think of this endometriosis, and any family history of the endometriosis, and severe dysmenorrhea, and pain interfering with the daily activities. Most of the time, if they elicit the history, there will be the girls who may not be going to the schools with the severe dysmenorrhea or some reasons. So the girls who are not going to the schools during monthly but frequent time means, then we can think that she may be having the endometriosis. And so the dysmenorrhea, absenteeism from school, and symptoms suspicious for endometriosis in adolescents. There is one paper which tells that the girls who have been absent from the schools finally have been diagnosed as the endometriosis. That is this pain affects the quality of life, and in future it results in infertility. The evolution, how we want to evolution. Do you think that the same, the endometriosis for the adult and the adolescents, everything is same? So how are we going to evaluate the adolescent? Most of the time we don't do the pervaginal examination. We, if at all needed, we go with the rectal. That is also nowadays not needed. So the history and the examination, mainly the imaging that is particularly with the MRI and the biomarkers sometimes. So these all are the challenges in the diagnosis. The clinical symptoms, what could be the symptoms means if the acyclical pain is 28%, irregular menses is 9%, and the cyclical pain is 9%, cyclic and acyclic pain is 63%. Sometimes they come with a history of UTI symptoms of 13% and the vaginal discharge of 6% and the gastrointestinal symptoms of 34%. All this Ds. So if you don't treat in during the adolescence, it may go for dysmenorrhea, dyspareunia, dysuria, dyschexia, DUB, diffuse abdominal pain, and difficulty in conception, and finally goes to the infertility. How are we first going to diagnose it? It is mainly with the ultrasonographic findings. With the USG, the picture of the endometriosis is unilateral or bilateral, unilocular or multilocular, and the mobility is always restricted because the tenderness will be present and the mural echogenic foci will be present, kissing ovaries, thin or thick septa will be present. Elicitations of the site-specific is very, very important. And the effect of the surrounding tissues, nodular wall thickening, these are all the features which tells that the girl may have the endometriosis. That is the low-level internal echoes and posterior acoustic enhancement called ground glass appearance. This is the main important point with the ultrasonographic features of the adolescent. This 3D, 4D color Doppler is also present. The blood flow in endometrioma is usually pericystic with a resistive index above 0.15. So there's a 0.45. These are all the differential diagnosis, but main differential modality for investigation. The CT scan has a very limited role, but it has its importance only in the lung endometriosis, scar endometriosis, and endometrioma. But to confirm the endometriosis in adolescents, MRI is very, very useful. MRI is useful for adolescent girls who are not sexually active in diagnosing the endometriosis. Sometimes it may not pick up the peritoneal endometriosis. This T1 and T2 weight images, along with fat suppression for T1 image, is taken along with the gadolinium contrast. So for endometrioma, the ideal is USG. In doubtful cases, you can go with the MRI, and which can differentiate it from the cystic teratoma. It is 90% sensitivity and 98% specificity. Why you want to treat this endometriosis in adolescent, and why we want to diagnose it? The main is they may not be knowing the reason for the pain. So the first is to relieve pain relief and the arrest of progressions of the disease. If you don't diagnose, it will go to the future, some infertility, additions, PID, like that, the complications. To arrest the progression, we want to diagnose it and treat it. Preservations of the fertility, if at all diagnosed also, we can have the modalities of treatment which can preserve the fertility. So the concept of medical management. Always for the adolescent, if it is diagnosed as the endometriosis, as far as possible, it is mainly to go with the medical management. That is, the medical management is suppress the estrogen and reduce the retrograde spill, overcome the progesterone resistant and anti-inflammatory aromatase inhibition. It can be the anti-angiogenic and immune modulations. So this is the way for the medical management. The main is always to give the pain relief. The girl is suffering from the pain and she is not able to go to the college or the school, means first thing is to relieve the pain. So the NSAIDs can be used for the pain, and it is sometimes least effective dose administered either before the onset or before the peak of the pain. Some girls, they know if the pain is going to start, they will go for the menstruation, and before the bleeding itself, they will start taking this NSAIDs. Mefenamic acid or ibuprofen or naproxen, and this can be used, and no side effects for this. The main side effect is being the gastritis. So sometimes if it is not reduced with that NSAID, means then we go for the hormonal management. So the progesterones mainly we use for the girls, the progesterones, rather than using the COCs. But in the later stages, we go with the COCs with the low dose estrogens. So the progesterones and antiprogestants, these are all the recommendations. That is, the clinicians recommend to use the progesterones. That is, normally we use the medroxyprogesterones. The most commonly used progesterone is the Dynogest. Previously, is the MPA and norethistron acetate has been used. Now the Dynogest 2 milligram per day, it can be recommended for the adolescent girls, and it has the best effect. The mode of action is being this, preventing this implantations, the progestins. The progestins is as effective as GnRH analogs. Dinosol we don't use for the adolescents. Sometimes it can go with the anti-androgenic effect. Medroxyprogesterone oral or SCRIM, and starting with the dose of 30 milligram per day. The side effect being the nausea and weight gain, fluid retention. And monitor the BMD reduction if used for more than 3 years. Sometimes we use only for the 1 or 2 years, and if it is used for more than 3 years, you can use the whether the bone marrow is density is normal or whether it has reduced. Nowadays, we even go with the depot medroxyprogesterone acetate. That is the injections of progesterones in the injection form. Once in 3 months, it can also be used. And there are studies which tells this progesterones is not going to interfere with the bone marrow density. The Dynogest, which I told, this is the newer progesterone. It is the selective 19-nor and progesterone activity, and the dose is 2 milligram per day, and the girls are also comfortable, and the tablet is also not having the side effect. It has an anti-proliferative, anti-angiogenic, and anti-inflammatory property. The pain relief is comparable to the GnRH agonist and has the minimal side effect, good safety profile and tolerability, and can be used for longer periods. We have seen some girls sometimes using it more than 2 years also. So this is a study, VISADA study, which tells to assess the safety in adolescents. It is approved by the pediatric committee, and it is approved by the European Median Agency, and the multicentric study, which was the Dynogest was used in 21 centers in the 6 European countries and found that it has been very useful and it is used for the 52 weeks. The Dinosol nowadays we don't use. It is an androgenic and the anti-estrogenic activities. Sometimes if the girls are sexually active or if they are cooperative, means you can go with the LNGIUS also. This is the second line management in adolescence. First line is only the progesterones and the pills, mainly with the Dynogest. The second line is the LNGIUS. It is effective is multiplied if LNGIUS is inserted following the primary. Most of the time, if you go for any surgeries, then it can be given as an LNGIUS. It also has the contraceptive benefits, but it is used mainly for the endometriosis. The newer drug therapies, now there is the elagolix, that is the GnRH analogs. There are some studies which tells the elagolix which can also be used, which is also reduces the pain. The pain relief is the main goal for the adolescent girls. So I have not used this elagolix, but some doctors, they have used this elagolix and that is the proven studies. So this progesterones and antagones and the SPRMs, that is the selective progesterone modulators, and SERMs are also can be the newer drug therapies. When to operate? As far as possible, the adolescent with the endometriosis, go with the NSAIDs. If not reduced, go with the hormonal treatment, mainly with the progesterone. And then if at all needed, you can go even for the IUD insertions and then use the Dynogest. And sometimes if at all needed, you can go with the elagolix. If it is not settled with everything, and then only we have the option of the endometriosis operations. That is the laparoscopic procedures, if at all needed. Endometriosis is also associated with the Mullerian anomalies. This is the pre-operative evolution. So before, if you are going to plan for the laparoscopic procedures, we have always to be kept in mind is the fertility preservation. So AMH has to be done more earlier, and the detailed imaging studies is must. And you can get the opinions of some seniors, because always to go with the, if you are going to have a first laparoscopic, means the first surgery should be the best surgery. You cannot do repeatedly the procedures. So the micro laparoscopy is preferable, and if at all needed, whatever is possible, the spots has to be removed. The principles to be followed is aim at eradicating the lesions and maintain the ovarian reserves and promote the fertility and relieve the pain and prevent the recurrence. Always it is our aim to prevent the recurrence, but if a recurrence is present, we have to go again. The Mullerian anomalies and endometriosis, what is the incidence? If there is some incidence of endometriosis with Mullerian anomalies, is around 5 to 11%. 72% of the girls with Mullerian anomalies with outflow obstructions have the endometriosis. The clinical outcome in patients with outflow tract obstructions differ from those without such obstructions. So there are about 5 to 11% of the cases with Mullerian anomalies and the endometriosis. This is the specific syndrome which is associated unilateral obstructions of the uterus didelphus at the level of the cervix or vagina, and then leads to the presence of hematometra, hematosalpinx, and ipsilateral renal agenesis. Sometimes it is associated with the endometrioma. These are all the other syndromes, Robert's uterus associated with endometriosis, and diagnosis always difficult because of the atypical symptoms. Always in the adolescent girls, most of the time they don't have the symptoms, so it is very difficult. The post-operative medical management can be OC pills or GnRH or anti-angiogenic can be used. Follow-up is very, very important. Long-term follow-up is needed, and the recurrence may occur in 30 to 51%. And the medical adjuvant therapy is needed. That can be the OCP initiated at an early stage to reduce the morbidity and the progression and go for the infertility. And the adolescents must be reviewed once in 6 months, and counseling is very, very must for the teenagers. This lifestyle modifications, that is always I used to tell 3 meals, 3 snacks, and 30 minutes exercise is very, very important for all the problems during the adolescence. They can avoid caffeine and alcohol. Vitamin B6, zinc, magnesium, evening primrose oil can be taken. This acupuncture, Chinese herbal medicine can be tried if they are interested. So the conclusion is, once the diagnosis is very earlier diagnosis is important to prevent the future complications. The first line management is focused on pain suppressions, and you can use the progestins and the LNGIUCDs and the latest drugs of the elagolix and oral GnRH agonist is used for the moderate to severe pain, and surgical if there is the failure of the management, only surgical, and it is for the refractory cases. And after the surgeries with the GnRH agonist, the add-back therapy is very, very important, and it is the multidisciplinary. Because of this pain, the mental disturbance will be there. So the integrating the cognitive behavioral therapy and other psychological interventions to manage chronic pain and associated anxiety and depression is needed. This is the use of AI-powered chatbots for symptom monitoring and virtual reality for pain distractions. The pain clinics is also important and it has to be diagnosed. Future, that can be the non-invasive biomarkers, which is the continued research is going on. I think that earlier intervention, that is shifting the focus to treating severe dysmenorrhea early as a risk factor for adolescent endometriosis. I thank you, and I thank can we prevent adult endometriosis if we treat adolescent endometriosis? Definitely not. So I thank Dr. Sheila Mane Madam and Dr. Ramani Devi for giving me this wonderful opportunity. And with their permission, and I make one request. I am Dr. Sampath Kumari from Chennai, from South, contesting for FOGSI President. The election year is 2026. The election time is August 1 to 10. Please, all of you, vote for me. After more than 30 years from South, we are from Tamil Nadu, we are contesting. Thank you.
Thank you.
Thank you very much, Dr. Sampath Kumari, ma'am. Fantastic talk. Apologies that we couldn't get the video sorted, but
yes,
it was a brilliant presentation. Thank you very much for your contribution.
Thank you. Just I would like to share something, Pratik.
Yes, ma'am.
As adolescent, you are mentioning, I had a patient who came with infertility, and when I palpated the abdomen, I found a mass. Okay. Got a
Yes,
scan
madam.
done. It turned out to be a big endometriotic cyst. And when I got a CA-125 done, it was 600 and odd. And it turned out to be malignant. When I called her mother and took the history, she told me that when she was adolescent, she underwent appendicectomy. And that time, the surgeons did mention that there were some spots of endometriosis on the pelvic peritoneum. I think we also have to see that if anybody is undergoing any surgery and these findings are there, and she came with infertility. So that was very unfortunate. Okay. But any surgery, if we have a slightest sign at such an early age, I think it will progress further and give rise to problem. So I really felt bad. She had to undergo hysterectomy because it was an endometrioid carcinoma. So, and she was just 26 years old. So that was one of the case I just thought I will share. So at any age, I think one should not neglect it. Yeah.
Yes, madam. It's really very.
Thank you, ma'am.
So sorry for not able to open my video.
I think there are some questions you can answer those in the chat.
Yes, madam.
You can put those in the chat box directly, ma'am. We'll proceed with the next lecture since we're already delayed. Dr. Ramani Devi is the convener of the course, and she is going to talk to us on a very exciting topic. That is the newer methods of non-invasive diagnosis. These are a lot of cutting-edge tests, many of which are not available in India, but hopefully over the next 5 to 10 years, we will see them. Thank you very much, Dr. Ramani Devi, President of TNFOG, previously Vice President of FOGSI, Chairperson of the FOGSI Endometriosis Committee, and she also authored the VCPR on endometriosis in 2017. Over to you.
Thank you, Dr. Pradeep. Let me share my screen. Today, I'm going to give a talk on non-invasive diagnosis of endometriosis. So many things are spoken about endometriosis, and the total thing has changed. Like, I'll make it into full screen. Okay. So I bring you greetings from my city, that is Tiruchirappalli. You can see the beautiful Kaveri and the rock fort and the UNESCO accredited Srirangam temple. So this is a beautiful picture that is seen in the painting seen in Italy, where you can see two young girls. You can see a chain in the hip that is made up of thorns, apples, and acorns, and a blush in the face. This picture is some 17th to 18th century, where it depicts the problems, that is a gripping pain the woman experiences, and apples are symbol of fertility which is delayed, and acorns are the fruits that take a very long time to grow. So when you look into the clinical trial, the number of trials are exponentially increasing year after the year, and there was a slight dip during the COVID period, and now again it has started increasing. So this definition is, by definition, it is the presence of normal endometriotic glands and stoma that is abnormally placed other than the uterine cavity. These implants grow and invade the tissue in the vicinity, causing inflammatory reactions. Then, according to American Society of Reproductive Medicine, it is now viewed as a chronic inflammatory disease that requires lifelong management plan with the goal of maximizing the use of only medical management and avoiding repetitive surgery. And the treatment of the goal has already been mentioned. It is we need to alleviate the pain and promote fertility, reduce recurrence, and improve the quality of the life. So the prevalence of endometriosis is also quite high. It is recent prevalence is 256 million women, they suffer from endometriosis globally, among which 50 million women are in India alone. Still, it will be a tip of an iceberg. And these are all the sites where endometriosis can affect. And the diagnostic delay varies from 6 years to 8 years. And that has been already mentioned. And when you look into the natural cause of the disease, there are various studies which shows that some 30% will progress, 30% will remain stable, and you see temporarily there can be a regression even in 40% of the patient. This is because whenever the immunogenicity of the individual is high, there is a chance that it might get regress. These are the varying phenotypes, and the algorithm for the diagnosis originally was a medical history, physical examination. We were giving importance for the serological markers, then presumptive diagnosis of pelvic endometriosis made, followed by transvaginal or transabdominal ultrasonography and MRI in needed cases, and ultimately the laparoscopy and biopsy, and confirmation by the histopathology to get the definitive diagnosis. But this whole algorithm has to be changed because now we know that just the symptoms and the sign as well as the non-invasive diagnosis are getting up more and more, so that individuals can get diagnosis of endometriosis earlier. That is history, clinical examination, imaging, biomarker. See, earlier in the 2022 ESHRE guideline says that biomarker should be, it should be done only in the research setting, but I'm sure in future it is going to be an effective method for diagnosing endometriosis. Then comes the trial of treatment, and there is currently no place for laparoscopy for diagnosis. So these are the 7 Ds for clinical history taking. And if a patient has got, the most important among the history is progressive progressive dysmenorrhea, and in a sexually active women, it is dyspareunia. Always it is a combination of multiple symptoms that has got more weightage to say that the patient suffers from endometriosis, and ultimately it is the depression and the fatigability. So then comes the clinical diagnosis, where a per speculum examination can show you a pouch of Douglas showing nodules, and preferably done during the menstruation period, and the uterus is invariably retroverted, fixed with a restricted mobility, and there can be adnexal masses. So it is according to Professor Chaperon, he says that there is no place for diagnostic laparoscopy when endometriosis is clinically suspected, and you need to start the patient on medical management. And there is no need to confirm the presence of endometriosis using histopathology according to various learned societies, including FOGSI, NICE guidelines, SOGC guidelines, and ESHRE guidelines. So the imaging, I can skip. Ultrasound, MRI, and CT are used. And Eva Brosens, he says that in 1997 itself, he suggested non-invasive techniques such as color Doppler, particularly MRI, will be suitable for diagnosis and follow-up of endometriosis. And it is, according to Professor Luc Rambatis of Monash University, they say that key paradigm shift in management of women with endometriosis is that we have specialists now who can diagnose endometriosis just on ultrasound. And this is the International Deep Endometriosis Analysis Group, who has divided the ultrasound examination into 4 steps, first step, second step, third, and fourth, so that they can analyze indirectly the evidences like the soft markers, presence of endometrioma, sliding sign, and the deep infiltrative endometriosis, all of which has been described in detail by my previous speaker. And these are all various signs like the comet sign, Indian headdress sign, and pulling sleeve sign, which can be seen in, especially in deep infiltrative endometriosis. So another interesting non-invasive diagnosis on imaging I came across was sonopodography. That it is a technique to visualize superficial endometriosis. We usually say that superficial endometriosis cannot be diagnosed with ultrasound, But by instillation of this saline into the pouch of Douglas via intrauterine balloon catheter, it will create the acoustic window between the ultrasound probe and the surrounding tissue. So this can mark out the small blobs or the surface irregularity, which is usually seen in the superficial endometriosis. And now they have identified that out of 42 patients, they had subjected for sonopodography plus ultrasound, and they found out it was positive in 57% by sono, and almost 88% of the participants had direct visualization through laparoscopy, which was found to be positive. Maybe as we work upon this, we can have we can pick up early lesions by this. Then MRI, I can just skip this. And another important message I came across when looking into MRI, we can find out that short anogenital distance in MRI as a marker for endometriosis. All of us know that in MRI, whenever there is the anogenital distance, that is the distance between the anterior renal verge to that of the posterior fornix, that is a small perineal area that is normally the cutoff is around 20 millimeter. If it is shorter than that, then if they say this woman is likely to have endometriosis, this is because of the pulling thing. So the patients with endometriosis, they have a shorter anogenital distance, which can be calculated simply by doing an MRI. Then comes the role of biomarkers. Biomarkers would have clear impact in reducing the diagnostic time, monitoring the progress of the disease and effectiveness of treatment. To replace invasive diagnostic methods, biomarkers could be considered clinically useful. Whenever you feel that it should be clinically useful, it should have a sensitivity of 94% and specificity of 79%. So this is a spider diagram to show that a lot of myriads of biochemical markers, biomarkers are there, which can be cytokines, which can be hormones, angiogenic factors, and others like cell-free DNA, antioxidants, and CRP, then proteomics, then apoptotic proteins, then addition molecules, then again antibodies, immunological complements, and then growth factors and glycoproteins. So there are so many biomarkers which are available, but we need to have selective biomarkers which can be clinically applicable. So here comes the microRNAs, and then again proteomes and metabolomes that can be used as a molecular marker for diagnosis. So not only isolation of this biomarkers, but it can be combined, a promising combined test using vaginal examination, ultrasound, and then serum interleukin 6, endometrial PGP 9.5, about which I will tell shortly, history, and then all these things put together, including CA125, is though it is non-specific, a combination of all these things, it can give us a good predictive value for diagnosis of endometriosis. So here, the source of samples for these biomarkers are, it could be taken from salivary miRNA, or it could be from the blood, or it could be a vaginal microbiome from the tissue, or the stool microbiome, or vaginal or cervical swab, or even the urine can have markers. And the candidates are glycoproteins, angiogenic, oxidative stress, inflammatory proteins, autoimmune markers, miRNA, DNA markers, and microbial and glycobiomarkers. So here, the same thing is repeated here. And then the important biomarkers are interleukin 6, 8, tumor necrosis factor alpha, highly sensitive CRP, cancer antigen CA125 and 1990, and then neutrophils and lymphocyte ratio and HE4. So among the glycoproteins are this, and growth factors, urocortin, activin, and follistatins are coming up in a big way. And then immunological markers like VEGF, we know that VEGF is elevated in endometriosis, and all these things I have already mentioned. And these are some of the microRNAs, and we should understand that each group of disease has got specific group of microRNAs which are dysregulated. For example, one group of set of microRNAs are dysregulated in endometriosis. It may be other set of microRNAs which are dysregulated in polycystic ovarian disease. So this can be used. So we now say that we don't give importance to CA125 for diagnosis because it's not specific, and in so many conditions it is elevated. but generally we take it as a cutoff of 35, and it has got a good sensitivity in severe disease, but whereas in early disease, it may not be of much use. So, but rather it can be used as a prognostic marker rather than diagnostic. But we have to understand that I had one patient who was a young girl, 18-year-old girl, who came with a CA 125 of more than 2000. So they had actually referred as a case of ovarian malignancy, but just a simple history, a progressive dysmenorrhea with a sudden acute onset of pain that shows with a grossly elevated CA 125 denotes rupture of endometrioma. Then comes the CA 1919, CA 199, that is comparing to CA 125, the specificity and sensitivity are quite higher than CA 125. And there are so many other markers also. Then macrophages. These are the source of EGF responsible for angiogenesis in men with endometriosis in response to tumor necrosis alpha and interleukins. According to some study, the level of tumor necrosis alpha is increased in patients with endometriosis and correlated with its severity. It has been observed to significantly increase in endometriotic lesion, especially in advanced stages. So again, then the natural killer cells. Normally, whenever there is regurgitated endometriotic cells into the peritoneal cavity, they are all cleared by the natural killer cells. So because of the cytotoxic activity. But in endometriosis, they have reduced natural killer cells, and they are not, or these cells can have are dysfunctional, and hence they cannot clear off the endometrial cells and leads to endometriosis. Interleukin 12 may inhibit the process of endometriosis by activating NK cells. Then interleukin 6 and tumor necrosis alpha, and they have a definite cutoff point, like interleukin 6 has got a cutoff point of more than 12.2 and tumor necrosis alpha more than 12.45 picograms per ml. They are found to have inconsistent results, and maybe under research settings it can be done. Then this was another interesting thing I noted, that the circulating serum has got endometrial cells. So the endometriosis, though it is a benign disease, it has got malignant features, and the presence of endometrial cells in the peripheral blood of patients with endometriosis are referred as circulating endometrial cells. And the CEC assay had 89.5% sensitivity and 87.5% specificity in distinguishing endometriosis from other benign ovarian masses. So it can be used as a biomarker because it fulfills the criteria for sensitivity and specificity, and comparatively it is a newer concept and it has to be investigated. Then comes the neutrophil lymphocytic ratio, where the woman with endometriosis has got neutrophilia along with lymphocytopenia. And then comes the soluble intercellular adhesive molecule, ICOG. It is believed that it is associated with reduced cytotoxic activity of the NK cells, and it is believed it may be relevant to implantation disorders and formation of endometrial lesions. Then integrins. Integrins are substances which cause increased additions, proliferation, and migration of the cells, and depolarized integrin was examined as a possible biomarker with a good sensitivity of 67 and specificity of 84%. So then again, serum HE4. Serum HE4 is a very promising marker in differentiating endometrioma from ovarian cancer, showing it has got a better diagnostic performance than CA 125. Then comes the predictive biomarkers for early lesion. Proteomics and genomics are coming into big place. Specific plasma biomarker obtained during menstruation that identifies the protein fingerprints, which are markers of the disease, and they are dysregulated. So proteomic technologies along with genetic profiling are newer modalities for non-invasive diagnosis, and salivary-based diagnosis of genetic marker. And again, we have a salivary-based miRNA that can be used in as a non-invasive diagnosis for endometriosis that has been brought about by Professor Philips Deschamps. Then it is again another simple technique how we can diagnose endometriosis. All of us know that endometriosis is a very painful condition, and in the endometrium of endometriotic patients, there is increased nerve fibers. Unmyelinated sensory C nerve fibers are they are increased in 14 times higher in patients with endometriosis, and they can be picked up by the pan-neuronal marker PGP 9.5 immunohistochemical staining, and they have found out that there is higher incidence of nerve fiber density. Again, there is one more study to say that there is increased density of these nerve fibers, and to conclude, endometrial biopsy with reduction of nerve fibers provided a reliability of diagnosis of endometriosis, which is close to the accuracy of laparoscopic assessment by an experienced laparoscopic surgeon. Then comes the microbiome. Nowadays, we know that each and everything microbiome, altered microbiome is the cause for the disease. So endometriosis again appears to be associated with increased presence of Proteobacteria, Enterobacteriaceae, then Streptococcus and E. coli across various microbiome sites. The phylum Firmicutes and Gardnerella appear to have association. However, it remains clear. To conclusion, there is a bidirectional relationship between microbiome and endometriosis, and the lactobacillus is always reduced, and the disease-causing microbiomes are increased. So again, there is abnormal microbiome profiling in the sample that has been obtained from the samples of endometrium, deep infiltrative lesions, vaginal fluid. So the DNA is extracted and the samples were analyzed to find out the GNAs. That is, NGS technology can pick up and the amplification they have picked up that there are a lot of abnormal bacteria and less predominant lactobacteria. Then again, from the microbiome analysis
we will
of
need to wind up, apologies.
Yeah, extra vesicle sites in the peritoneal fluid has got abnormal microbiome. So this is our paper. And again, coming to the microRNAs, these microRNAs can be picked up in various sites from the endometrioma and the peritoneal thing. And this was a study by Koser et al. In 2016, where he had found out this microRNAs 125, 150 and 342 are upregulated, and it is microRNA 3613 which is downregulated, and this is practically possible to detect these microRNAs from the saliva or from the serum, and they have found out that there is a definite differentiation, dysregulation in these control group versus the endometriosis, and again, irrespective of the stage of the disease. For example, the CA125, all those things, biomarkers are increased only in the advanced stages, but these microRNAs they are irrespective of the stage of the disease, it is all dysregulated. So this is again, we have got, so this potential biomarkers these are the important one where you have got a very good p-value and can be used. Definitely in future, it is going to be the thing, and they will be soon developing a kit for non-invasive diagnosis of endometriosis, just putting a serum and like just a pregnancy kit we can diagnose in patients who are suspected to have endometriosis. Again, mitochondrial mutations can also still be used as a potential biomarker, and each mitochondria, multiple mitochondria are seen in each cell, and there may be mitochondrial genome, multiple things. There is mutation rate is 100-fold higher than in the nuclear genome in patients with endometriosis. To summarize, urgent unmet clinical need for non-invasive biomarker in endometriosis. No clinically proven biomarker is yet available. Large collaborative studies are needed, and it is an enigmatic disease that takes long time for diagnosis. So far, laparoscopy is found to be the gold standard. Now, currently, imaging studies are gaining popularity. Early diagnosis by imaging still has got its limitation, and we need novel methods for early diagnosis to reduce the morbidity. And this development of these biomarkers are very important for diagnosis and proper treatment and follow-up. And we have this CA125-99 genomics, endometrial nerve fibers, microbiome, microRNAs, which are going to be the future diagnostic modalities for non-invasive diagnosis. And ultimately, I thank the ICOG, Dr. Sheila Mane, for having allowed me to do this certificate course. Thank you.
Thank you very much, Dr. Ramani, for an excellent overview of all the new cutting-edge tests and research that we have on non-invasive diagnosis. Hopefully, as you said, over the next few years, we will be able to have more and more of these tests, just like a pregnancy kit test, which will be able to diagnose endometriosis in early fashion, because the late diagnosis is the primary driver of the pain and suffering of these women. So thank you very much to our excellent speakers, Drs. Lakshmi Shekhande, Sampath Kumari, Archana Basir, and Ramli Devi. Thanks to my co-chairpersons Dr. Sneha Boyar and Dr. Chinmay Ratha. Any closing remarks from Chinmay? We are already 10 minutes late, and then we can go to the next
I
session.
think Dr. Kanti can conclude. Dr. Kanti.
Kanti is the next speaker.
I think it's been a great session. The questions are also showing that people are engaged. And since they are all being answered there, we'll move on, sir. It was quite an
Fantastic.
eye-opening session.
So
I
we'd like to introduce the next set of chairpersons.
Yeah. I would like to thank Dr. Prateek and Chinmay for this wonderful chairing the sessions. It was indeed a pleasure listening to all the speakers, especially my dear friend Dr. Ramani Devi. And now I call upon the next session, the chairpersons, Dr. Arun Arora, Dr. Abha Rani Sinha, Dr. Chaitanya Ganpule, Dr. Sita Ramamurthy Pal. Most welcome. Yeah, I'm not, should I read it?
No, that's
No,
fine.
not
That's fine.
me.
We're already 15 minutes over time.
Yeah.
Let's go ahead with the introduction of the first speaker. Dr. Arun Arora is here. Sir, requesting you to introduce Dr. Kanti Bansal.
I think this also we can cut it off. It's okay.
All right.
Welcome, Dr. Kanti.
Yeah. I'm very happy to be the ICOG Governing Council member. I think that's the thing what I want to tell everyone. That's it. Yeah. Shall I start my screen if you don't mind?
Please go ahead. So Dr. Kanti has written a textbook on endometriosis herself. So let's see how she compresses that knowledge into 15 minutes. It's a challenging task.
Why am I?
You just need to go full screen. Slideshow from beginning.
Oh, yeah. Prateek, I need your help always. Thank you.
Thank you. Go ahead.
A very interesting talk indeed. Thanks to Dr. Ramani Devi. I think once Ramani Devi, I had been the founder chairperson of this endometriosis committee, and then there's no looking back with all my followers as well. So what's new? What's the changing trend in medical management? So there's a shift from the surgical first to the medical first approach now.
Can she have a slideshow, Prateek, or there is a problem?
This is the slideshow only.
Ma'am, please
The
speak
slides
for
are not
us.
moving.
It's not
Madam,
looking
you have
like
to click from the beginning.
Just a minute.
But she can see it as full screen, so maybe you'll have to stop share and do it.
Just a minute.
Dr. Sampath had the same issue. Dr. Vidya Tobe is not with us, but she frequently has the same issue.
Can you see now?
Yes,
yeah, perfect.
absolutely perfect.
That's okay. I don't know why this problem is there. So there's a shift from the surgical first to medical first approach. I always feel conventional methods are better than the surgical. So in the past, we had diagnostic laparoscopy earlier. Now the present trend is empirical medical first line. Surgery reserved for select indications.
Click on the slide, ma'am.
Yeah, it's okay. So there's a changing paradigm in the endometriosis. This chronic inflammatory estrogen dependent disease, we all know that there's neuroangiogenesis and immune dysregulation, which is recognized. And this is shift from the suppressive therapy to targeted molecular modulation. That's the main switch now. Now, what was a traditional medical therapy? NSAIDs, combined oral contraceptives, progestins, GnRH agonist, and danazole. Danazole is absolutely having declining use because of its, all the complications, and it's really not used because of the, hoarseness of voice and side effects of danazole. Now, the old concept was suppress the menstruation. The new concept is long-term disease modulation, estrogen suppression. That's very important because we all know that the main culprit of endometriosis is estrogen, and we need to suppress it. And also because of this, we have also inflammation, which has to be controlled, and continuous therapy approach is the norm now. Evolution of therapy, 1990s, we had ovarian suppression. 2000s, we have continuous hormonal therapy. 2010s, we had LNG-IUS and long-term suppression. Now, 2020s, we have our oral GnRH antagonists and precision medicine. So guideline-based first-line therapy, that is, as we all know, the COCs. Then oral progestins, in this, the Dynogest was very much preferred. And then we had the LNG-IUS. Of course, the LNG-IUS had very specific roles. As it could be used only in some particular patients and not in all patients. Now, Dynogest, a modern cornerstone, selective progestin with anti-inflammatory action, anti-angiogenic and anti-proliferative effects are seen with Dynogest, effective long-term suppression. And when we had this Dynogest, I think it was a new molecule when I became the endometriosis committee chairperson in the 2013, and had gone from to every corner of India, talking about Dynogest, and I had made it a #1 molecule. And now there is this, then after that we had the GnRH agonist, which was very widely used because it was not a daily, it was not to be given daily, just once a month medication. So that was preferred by some of the physicians, and comparable pain and recurrence control were there, and better tolerability and safety. Now, LNG-IUS, as I told you, local progesterone dominance is there and reduces in a lot of this dysmenorrhea and discomfort in the patients, and also it reduces the recurrence. And it can be used for a long time, and then that is one of the benefits. Now, there are some major recent trends from 2023 to 2026. Rise of the oral GnRH antagonist, personalized add-back therapy, long-term progestin suppression, and targeted molecular therapy. So now there is a shift, as I told you, from agonist we came to antagonist. So it's a rapid onset, and there's no flare. We used to have a flare of FSH, and because of the agonist, and then that flare is to give rise to more of estrogen, which is to in turn really increase the endometriosis. But in antagonist, that is not there. Dose dependent estrogen suppression, better reversibility. Now we have several molecules in antagonists. We have the very first one, the elagolix, then we have relugolix, linzagolix, oral dosing and individualized estrogen control. Here, I want to just share with you all that during the AICOG, I had presented my own research work, which I had done on oral elagolix. And this is a real world study. And here we had done around, we thought of 50, but we could do about half of it. It was an interim analysis that I presented. And the antagonists, both doses we had used. In some patients, we used 150 milligram OD, and in the other patients, we used 200 milligrams BD. And in this, we showed that the VAS score had decreased. It was not only about the pain, but we had taken the pain also. And what was very interesting, which is actually not shown in many of the studies, is we also showed the lesion increase. So we had also taken up the adenomyosis cases and the endometriomas. And in the endometriomas also, we saw that this is significant decrease in the size. So the next, the study will be completed by May, I suppose, I wish, and I'll be presenting in the Aspire. So efficacy, significant reduction in dysmenorrhea and also non-menstrual pelvic pain. Improved quality of life is there with this, because you just have to swallow some tablets, that's it. And I have not seen any patient complain of any problems after taking this medicine. Nobody has stopped in between. The only thing they complain, my patients are generally infertility patients, they complain that we're not getting menses. So we need to counsel them beforehand that you will not be getting menstruation when you are having the antagonist. Now, relevolics combination therapy. So here what we do, GnRH antagonist plus a little bit of estradiol and norethistron. So that will, in a long term, if it's continue to give antagonist, it will have its side effects. So to combat that, we do give estradiol and norethistron. Then this will maintain the bone density and enables long-term use. We have to counsel our patients about this problem. Add-back therapy personalization, tailored based on the bone marrow density risk, improves tolerability and adherence. Now, the aromatase inhibitors expanding role. Here we do use letrozole, and this suppresses local estrogen production and useful in refractory and recurrent disease. I can just quote another very personalized, treatment that myself, Dr. Ramani Devi, had done in many of our cases, because we get the most difficult cases. Ramani is also doing the surgical, but I do only conservative, and otherwise I report to some surgeon. So what we used to do is to use Dynogist plus letrozole, and in some cases also GnRH agonist. Very stubborn cases, we had to do it, but these combinations were not for a very long term, because we don't know, we have not done any study on that, but maybe we should do it in the future. Now, a combination of aromatase inhibitor therapy, the letrozole and progestin or GnRH therapy is quite good. That's what I told you, which we did. And dual estrogen suppression strategy can also be done. Now, declining role of, it's very important, because I have seen the rural practitioners still go on giving danazole, and we need to change it because of its side effects and complications that it gives. So there's a significant androgenic and metabolic effects, and it is no longer recommended in modern guidelines. That is important for all the people listening here to understand that danazole should not be given now, because we have so many newer molecules in medical management. Targeting inflammation and immunity. This is still experimental, but in the long run, I think it will be there. That is a TNF alpha inhibitors. And also we do have the immune modulation strategies coming up now. Anti-angiogenic therapy, target VEGF pathway and reduce lesion vascularization. I think this reducing the lesion vascularization will be the third thing that will really affect the treatment factor. Now, neurogenic inflammation targeting. We heard so much from Dr. Ramani Devi regarding the nerve fibers that are there. And, I have one patient who had such severe endometriosis, but it was all treated so wrongly. And ultimately, we had to get her uterus removed. And then even now, she was complaining so much. The patient was from Bangalore, and she had problem of nerve fiber, nerve so much of tingling, so much of nerve problems. So I had to refer her to a neurosurgeon, and then he said that we can't do anything, and then she'll have to be with that throughout her life. So these are some of the very sad things that we see in our patients. So nerve fiber proliferation. So there's a nerve fiber proliferation which drives the pain. We have to keep it in mind, and we need to do some neuromodulators which can come and get these things solved up. Post-surgical medical suppression, long-term progestins reduce recurrence. So this is a very simple treatment which we can use for the post-surgical medical suppression. We have to keep in mind that just doing the surgery will not help us, but we do need to continue to give some form of reducing these to reduce the recurrences. Initially, Dynogest was widely adopted. Now we are also using letrozole. We can use antagonists, etc. Now now I'm coming to the post-operative GnRH antagonists. There's definitely emerging role in the recurrence prevention, and it has a faster recovery versus agonists. So GnRH antagonists are coming in a big way, and I think our endometriosis patients will be really, really benefited. Precision medical approach, we have to now think about the phenotype based therapy, which phenotype requires which molecule, and pain versus infertility dominance. So generally when I talk to other doctors who are doing general gynecology, they have different problems than that which is seen for us fertility specialist. In our case, we cannot go on giving suppressing drugs, even these antagonists for a long time. The patients want to stop and then go in for the fertility treatment. So there's a lot of judgment, and we have to go with a lot of gentle love and affection sort of a treatment with these patients. Age and metabolic risk consideration is also there. So as the age increases, maybe the patient is going for the menopause, and then maybe the disease per se will decrease. But then there is also a turn to it. There can be a metabolic risk in these patients. Now, phenotype specific therapy for the peritoneal, we can just have the COCs or the Dynogest. So Dynogest is still there, but then it has specific indications. Then for the ovarian, we can use the LNG and IUS or Dynogest again. And for the DIE cases, we can use GnRH antagonist plus minus letrozole, that the aromatase inhibitor. So remember that you can always combine two molecules to get the best for your patients if they're not getting their problems relieved. Now there are emerging molecular targets like I like that music. Selective progesterone receptor modulators, epigenetic modulators, and antifibrotic agents. Microbiome, even Dr. Ramani told that it is there in the, everywhere, microbiome, and we know why it is there.
Hello.
I think some technical glitch.
Yeah.
She had finished her presentation, so we can go ahead with the next speaker, I believe.
Is Madam there? No, she's also doctor, I guess. Yeah, we
If
could.
Dr. Epsiba is not there, then we can have Dr. Pradeep Kumar Mehta.
Sorry, sir.
Hepzibah is there.
Technical glitch, sir.
No worries.
No
We can
worries.
go ahead.
Dr. Hepzibah is here. I thought I just saw her. Maybe she got
Okay, because
locked
she's
out.
posted a message in the group saying that she can't log in. Ah, I saw her. Yes, there she is.
Hello. I'm there. I'm Dr. Hepzibah.
Yes, ma'am, we can hear you. There's an echo. Please log out from your phone.
Yeah. Shall I start the screen?
Yes, ma'am, your screen is going to be seen in just 2 minutes. We'll just formally introduce you first.
No, yeah. Thank you.
Please log out from the other device.
May I?
Yes, ma'am, please go ahead.
Thank you. So it's a pleasure and honor to be part of this endometriosis certification course. And thank you, ICOG, opportunity, and it's my privilege to introduce Professor Hepzibah Kirubamani, a very senior obstetrician, has been the past president of OGSSI, past president of the Chennai Menopause Society, and has been an active member of the ICOG as well, teacher of teachers, and she's had received multiple awards. We are going to listen to her about endometriosis in perimenopausal women, which is often quite neglected. And I remember a case where we had one woman with ovarian abscess, which was a long-standing endometrioma. So all yours, madam, to take up this topic. Thank you so much.
You
can share your screen, madam. Yeah.
Yeah, I have to share.
Madam, you need to log out from another device because it's echoing your voice. Are you muted from the device you're speaking?
You'll have to unmute from this one now. Yeah.
Yeah.
I have to rejoin.
No, we can hear you. Only I
But
would
I'm
suggest you
unable
log
to
out from
share
your
my
phone.
screen.
என்னாச்சு ரிசல்ட் என்னாச்சு யார் ஜெயிச்சா உங்க இதுல சரி ஓகே ஓகே
No, I'm not able to share my screen.
Madam, there's an icon below at the bottom of your screen which says
கீதாவும் என்னோட ரிலேட்டிவ்
green
தான்
button showing an arrow.
Yeah. But
சொல்லுங்க
You're not
சொல்லுங்க
able to share?
சொல்லல
shall I rejoin again? I'm not
சரி
unable to this thing. They keep moving.
recording in progress.
Yes.
Any luck, madam?
The host is not allowing the participant to unmute.
Ma'am, you are already co-host, ma'am.
But I'm not, see, everything is.
Ma'am, actually you are logged in with the two devices, ma'am.
Can you log out of your phone?
No, I am not logged in, only through my system.
You are
Actually,
still logged in into your phone, and that is why there is an
Pratik, actually, even I was not able to join, and then it was all
No, I
muted.
joined only through my system.
So then what I would suggest is let's go with the next speaker. In the meantime, she can log out and log in again. We can go with Dr. Pradeep Kumar Maitra, and we can have Dr. Epsipa lead.
Yes, madam, please try rejoining again.
In the meantime, you can log out and log in again, ma'am. Let's finish this 15-minute lecture and we'll have you after.
Selvi
Should I introduce, or is Dr. Arun Arora? Dr. Abha ma'am and Dr. Chaitanya are not here, I guess, yeah?
You can go ahead.
Yeah. So again, a proud privilege to introduce Dr. Pradeep Kumar Mitra from the Bengal Society, past president of our society, and has been a very active member of the Endometriosis Society of India in Kolkata, and propagating all about endometriosis. All yours, Pradeep da, for your talk. Thank you.
Can you hear me, Sita?
Yes, sir. Yes, sir.
Can you hear me? Okay. Let me try to share the screen. If there's a problem.
You did say you had sent your PPT, right?
Yeah. If possible, yeah. Can you see the slides?
Not yet,
Not
sir.
yet, sir.
Hello.
Not yet. Not
I have
yet.
shared it.
We can't see it,
Shreya,
sir.
backend team.
Yes, sir.
Can you
Can
please
I share?
assist us?
Yes, sir.
You can go ahead and share, and he will say next slide, next slide.
Yeah, that's it.
Shreya, I have shared you sir's PPT.
What is happening?
Dr. Epsipa was unable to speak, ma'am. There was some technical issue.
Pradeep da, is that?
The next speaker.
Yeah.
Is it okay?
Yes, sir. Please go ahead.
Okay, thank you. Actually, I was a bit confused regarding my topic. Awareness for whom? What you see usually in our global awareness day for any disease, we teach ourselves in various seminars, various symposiums sponsored by various pharmaceutical companies. Only awareness, sporadically in the awareness month, what is being done? Do you think is it enough? I feel never it is enough. Secondly, creating awareness in patients. What does it mean? Who are the patients? Is it really helpful when one comes to you as a no patient? Of course not. And lastly, creating awareness for clinicians. And who are those clinicians? Are they qualified gynecologists, or the general practitioners, or the grassroots level medical care providers? I think last two are quite pertinent to give awareness through teaching. And fourth one, only awareness is enough. I also don't think it is enough. Screening at the bottom line level, entire rural population particularly, then semi-urban, and then urban population should be the ideal approach. Next one. Next one, please. Yeah. Now we have learned a lot about this earliest detection with various tests, but saliva test, micro test, and symptom followed by ultrasonography, followed by laparoscopic diagnosis. On the other side, there are two clinical areas. Is it possible to do the same for the mass screening? Again, the answer is no, not at all. Next one, please. Next. Next one. Next slide. Yeah. As we all know, it is one non-curable lifelong disease with most unspecific causative factor, which is not yet known, and there is no pre-endometriotic stage, unlike cancer, and there is no validated biomarkers. And in my experience, I have found more than 50 to 70% adolescent girls are suspected to have endometriosis, and it is considered one global epidemic. And what we see is just the tip of the iceberg, and we should do the screening for entire population. So suspicion followed by earliest detection and confirmation should have been the goal of us. Next one. Next slide, please. Next slide. Yeah. 14 years back, our living legend taught us 3 points. One, prediction and prevention. Then catch them early and strike at the root. Adolescent should be diagnosed clinically, and there is a very important role or vital load of awareness come screening program for peri-adolescents. Next one. Next. So what should be our targeted population? On one side, I felt those should be peri-adolescent, mostly adolescent girls with their boyfriends as well, I believe, and then parents and guardians. And the other side, the next key persons are number one, class teachers and the general practitioners as a whole in the form of village co-ops, paramedical staffs, health workers, and last but not the least is the society. Society as a whole should be the targeted area of us. Next one. Next slide. Next slide, please. Well, I was very passionate of this awareness program since my younger age. You see, in way back 2000, previous one, please. Previous one. Previous slide. Previous slide, please. Well, it is not working. I'm just skipping that part. In the younger days of my life, I've seen all the teachers, the guardians, or the students, they have never heard of a disease called endometriosis. In contrast, they all know that cyst in the ovary or polycystic ovary, they know about it. And the scenario remains unchanged even today, 2026, but I failed. So there are 3 approaches of these things. Number one, to go or identify or go for the awareness in all the school as far as practicable. And secondly, to teach the ground level practitioners, and thirdly, try to detect the apparently asymptomatic endometriosis with the help of our physicians. I'll come to that later. Next slide, please. Oh, well, here I can see I was trying to show what we did in villages. We are habituated to see, yes, that was the slide and what I was talking about. And we have used school visits, rallies, medias, and medias for the entire endometriosis awareness program. And I told already that the scenario remained unchanged so far. Understanding the name of endometriosis among the students or any sector of our society. Next one, please, which is showing we have seen the rallies, political rallies everywhere, particularly West Bengal nowadays. But have you seen rally being held for the awareness of a particular disease. Yes, it is being done from our end, from Endometriosis Society, that I was trying to show in my next slide. Next slide, please. Yes, this was the video, but unfortunately I cannot run the video over here. This is the big rally which has been held in different villages, where they used to show the poster showing information on endometriosis and go down the entire village. Next one. Next one, please. Yeah. Next one is this awareness for the parents. Next one. Next. The same COVID time. Next one. That is also in society and the village area, the rural area. I used to work in the remote rural areas for the endometriosis, and also all sorts of media, including TV program, where in the form of panel discussion, this awareness had been done. Next. Yeah, this is a lifetime memory of mine. You can see Dr. B.N. Chakraborty and Dr. P. with me in a first and probably last time live program on endometriosis awareness, and it's a very memorable program for me. Next one, please. Next. And even we used to use the festive seasons, where you can see the boys and girls are holding. Just a minute, please go back. Boys and girls used to hold these posters showing the features of endometriosis, and they mix up with the visitors of the various Pujaman pandals, and they give awareness to those people. So at one point in the year 2018, I felt that only awareness might not have served our purposes. That should be screening as well at the same time. And why these are the facts written over here? Number one, the incidence of dysmenorrhea and chronic pelvic pain or non-menstrual pelvic pain, its incidence is increasing progressively. Secondly, mostly this is being ignored by the parents and the school teachers. Girls suffer compelled to accept it is part of life, and most cases are detected very late. The onset detection interval is more than 8 to 10 years, and it progresses at the rate of 10% per year. It is geographical variation of India, and not only affects the urban but rural sector as well, I've already said. And transgenders and gender expansive individuals, they're also being affected. So we have two failures I observed in my career. One was we failed to study the issue in a very systematic manner. And secondly, we advised sporadically without any follow-up. So our journey started in the next step. Next one. Next. So with the object to suspect and provisionally diagnose the disease by non-invasive approaches, to avoid the usual diagnostic delay of 8 to 10 years in endometriosis, and thereafter, three things: to promote a lifetime plan, to avoid various difficult and complicated surgical procedures, to promote conception, and to maintain optimum quality of life. And I have always said we have made attempt to detect asymptomatic endoadenocomplex. Next. So the first, I have already said there are three approaches. The first and foremost one is awareness cum screening program. Here the crucial role is being played by social welfare organization and endo warriors. And here you can see the first is the prior to the program distribution of endo survey form is being done. This is followed by a basic lecture or a panel discussion on endometriosis for about 40 minutes. And all the girl students are giving a slip paper to write any queries without mentioning their name but mentioning their class and age. And at the end of this session, either in the lecture or in the panel discussion, we used to take up, collect all those slips, and all the questions were being answered, and it took nearly 1 hour or so. And then thereafter, collection of all endo survey forms were being done, and another date was fixed for the checkup and advised. Next one, please. Next slide. Yeah, here you can see the first program is being done, and the second day, all the students were being scrutinized, and the subsequent visit is being made for subsequent advice or next procedure. Next one. Next one. Yeah. Next one is here 5. Yeah. This is the most important part, the endo screening form. This is the first page. This is the hard copy, and we have also digital copy as well. Next one, this is the first page of this endo survey form or endo screening form. Next one, next slide. And this is the second page. Next slide. Yes, and we're trying to do since 2004 to have a link for to reach the grassroots level and to make a widespread national program, and it is being monitored by trained class teachers, social workers, and warriors under the remote supervision of a gynecologist. Next one. Next slide. Next. Yeah, this is the pilot study where you can see the endocyte forms which have been filled up by the students, and more than 4,000 participants have been screenized. And next one. And a symptom-based grading had been done for grade 1, that means no or mild vague pain, they are taken as control, and grade 2, progressive dysmenorrhea with a VAS between 7 plus minus 2. Then grade 3, chronic pelvic pain and non-progressive non-menstrual pelvic pain, and grade 4, progressive dysmenorrhea and chronic pelvic pain causing incapacitation of normal activities, and grade 5 as chronic pelvic pain or progressive dysmenorrhea with bowel or urological symptoms. Next one. So about more than 4,000 patients had been recruited. I'll be showing one study. Next one. Next one. And this is the pre-treatment scenario after scrutinization of those endo screening form, and those who are having grade 2 problems, they were given analgesics or NSAID and watched for 3 cycles. 10% became asymptomatic, but remaining 90% in them symptom persisted, and we went for trial drug therapy for grade 3, 4, and 5 in the form of continuous low dose OCP for 3 to 6 months after exclusion of basic contraindication of OCP, and observe the outcome. Next one. Next one. Yeah. And on analysis, we found that 70% of the girls became amenorrheic and got partial to complete relief, and the provisional diagnosis of endometriosis could be made in them, and they were advocated to continue the same treatment for another 3 months, and they were followed up. But remaining 30% did not get much relief, and particularly with this COCP. Next. And for them, ultrasonography was done in the form of transabdominal, transperineal, or transrectal, and in few cases, well, obvious abnormality to be detected, but in others, there were not much problem ultrasonography, and all of them who could afford were given Danogest, and they were referred to tertiary center for review, high resolution ultrasonography, MRI, or laparoscopy, and proceed as the need. Next one. This is the statistical interpretation. I am not going into that. Next one. Next slide. So I feel the good coordination between NGOs, class teachers, endo warriors, and the gynecologist is the key to success with regular follow-up of this awareness program for endometriosis. Next one. And you can see the endo warriors. They're the key persons. They're the youths being trained to conduct public awareness and social provided by NGOs to serve in various districts. I had conducted in 10 districts in West Bengal. They reached the grassroots levels to provide studies. Their friends and colleagues, they are inspired, and they are the endo survivors, particularly adolescent endo survivors. They and their friends is to go into this particular program. And here you can see they were appreciated. They received appreciation award in International Conference of Endometriosis in 2003 in Kolkata. Next one. Next one, please. The second way, yes, this part is important. There are two components of this portion. One is how to train the general practitioner and the paramedics. You can see the same procedure, the same lecture or a panel discussion is being made for them, and the questions from them were being answered by the person concerned who has using there to train them. And next one, next slide, please. And the second part, just click it. Next. This is the second part for next. Yeah, waiting room survey and posters. It is being requested to all the practitioners to show information regarding endometriosis or display posters with information on endometriosis on one side, and the other one is waiting room survey. That is a simple endo survey form or screening form was over to them, and the receptionist there at the clinic, they used to fill up that form for all girl patients and highlight the areas those are positive. So when the visit comes, the doctor at a glance could see what's the basic problem, and instantly he or she, the doctor concerned, could refer the patient to the hospital or the gynecologist. And in this approach, the outcome we found that more than 40% of the girls had dysmenorrhea, which is being progressed on
Sorry to
non-menstrual
interrupt you, sir. Your time is up.
Okay, very quickly, I'm skipping. You just show the slide. This is the primary prevention. Next one, please. Yes, this lifestyle modification is very important. Food is important. Next, just show the slide one after another and end it up. Then sedentary habit is important, that is to be avoided, particularly cell phone, its impact on the brain, the electromagnetic waves on brain, how it affects. It has been shown over here. Next one, please. Yeah, there is various side effects. I'm not going into detail, but it has a very important role in symptom tracking, and their application is the endometriosis. Next one. Yes, home remedies, role of alcohol and smoking is being informed their harmful effects. Next. This is asymptomatic endometriosis detection from our general laparoscopic surgeons and sonologists on request. Next one. Well, this is the outcome of the project. Next. So endo registry is to be maintained both in baseline screening and also for non-responders at the tertiary level center. We did it. Next one. And appropriate diagnosis to be made with multidisciplinary approaches involving gastroenterologists, urologists, psychologists, psychiatrists, etc. Next one. Skip that one. Next one. This is the MRI features of tertiary level. These are the mini lab features. Next one. Well, even normal looking endometrium do have endometriosis, which I've shown in the last slide, where a deep scanning in electron microscopy and proper management of the thorough counseling is being done at the tertiary center.
Sorry to interrupt you, sir. Can we wind it up?
Okay. So the final line is that with this type of approach, substantial reduction of onset detection interval is possible with avoidance of extensive surgery and recurrence, and optimum quality of life may be achieved from adolescent onwards. Next slide. So awareness should be made on every day throughout the year, not on one day, so that we do not miss the bus. Thank you very much for patient hearing.
Thank you so much, sir, for your in-depth analysis of how do we make people aware of this dreaded disease. We now move on to Dr. Hepzibah. Madam, you're ready with your PPT.
Very nice presentation and nice initiative, Dr. Pradeep. I think because of this certificate course, many of us, we came to know about it. Okay.
Sir does a lot of work in our public awareness committee for not only endometriosis, a lot of other things. So we have been witness to that. Thank you, Pradeep, for that.
Good to know that. Yeah.
Dr. Hepzibah, you ready?
Can I request Dr. Arun to introduce Dr. Hepzibah?
Can I have the CV, please?
Yeah, she'll share her slide and then the first slide.
Welcome, Professor Hepzibah. She is former superintendent government RSRM Hospital. She is past president of Obs and Gynae Society of Southern India, past president of Chennai Menopause Society, past IMS chairperson for Education Committee. Besides all these things, she has developed Midlife and Beyond app, Preeclampsia app, reminder app for MOM, directed to short films for menopause awareness, written textbooks.
Thank you, sir.
Ma'am, your voice is still echoing. Please sort that out. Yeah, it's fine now.
There's a very bad echo which is still persisting. Back then, can you hear me, please?
Yes. I think, can you hear me?
Yeah, we can hear you properly now. Thank you, ma'am. Please go ahead.
Yes. So a few questions came to my mind. What is its incidence? What is its pathology? What is its clinical presentation, diagnostic modality, treatment goals, and risk of malignant transformation? As per recent estimates by WHO, about 196 million women suffer from endometriosis globally. Of this, 50 million women belong to India alone. So endometriosis should be viewed as a chronic inflammatory disease that requires lifelong management plan with the goal of maximizing the use of medical treatment and avoiding repeated surgical procedure. So endometriosis is not a problem slowly of reproductive years. And there are some misunderstanding around endometriosis, including that hysterectomy, pregnancy, menopause will end the pain, but this is not always the case. And there is a paradigm shift in thoughts about endometriosis. We think that it should regress in parallel with the regression of gonadal steroidogenesis during menopausal transition, and we pursue. But the elevation in symptoms during menopausal transition has not been shown in longitudinal studies, and it took more than 250 years to appreciate that endometriosis occur in postmenopausal ladies also. And WHO has defined, it's a menopause society, also defined that a period of 2 to 8 years preceding menopause and last up to 1 year after the last menstruation. Actually, it's a challenge for attending doctor and the patient. And 16.7% had a perimenopausal endometriosis when they studied 184 and around 45 to 54 years, and 4.6 patients had around 46 years. And when they studied total of 16,969, 40.33% admitted to hospital for treatment of endometriosis were over the age of 40 years. So coming to the pathology, perimenopausal is even more complex because it is not known whether it is a continuation of previous disease or it develops de novo. So the probable explanation during perimenopause, it's a metaplasia, induction of endometriotic implants through continued gonadal steroidogenesis, exogenous estrogen administration, peripheral aromatization by adipose tissue, in situ aromatization with the cycle of estrogen stimulating cyclogenic activity, and prostaglandin might stimulate aromatization. So coming to the clinical presentation, they may have pelvic pain or mass, and the symptoms will be related to the location of endometriotic lesion. And even cutaneous endometriosis has been reported in postmenopausal women. Intestinal, urethral obstruction, and hepatic endometriosis also have been reported in the literature. So the diagnosis is based on, like any other case, based on history, symptoms, corroborated physical findings, imaging technique, and finally the gold standard is the histological examination. So the combination, the gold standard for diagnosis is only histopathology. Like any other endometriosis, during this period also, the ultrasound gives so much benefit to us. It can pick up a lot of things. And CDS recommends that clinicians should assess the urethra, the bladder, the bowel involvement,
by additional imaging if there is a suspicion based on history or physical examination of deep endometriosis during preparation for further management. So coming to the biomarker, it is actually CA125, it's an adjunct, it's not for confirmation. A lot of emerging novel biomarkers are available like microRNA, glycoprotein, peritoneal fluid, endometrial tissue biomarkers, genetic and epigenetic matters. But right now, the diagnosis is still largely based on clinical suspicion, imaging, and the gold standard is laparoscope. So the associated conditions to be ruled out are ovarian and para-ovarian cyst, fibroid, adenomyosis, endometriosis, associated ovarian cancer, bowel cancer, uterine cancer. So the treatment goal is to alleviate pain, reduce recurrence, improve quality of life. So it can be surgical, medical, combined, and lifestyle modification. The important consideration in this age group include diminished fertility and impending menopause. The diagnosis and treatment for endometriosis associated infertility must be undertaken in an expedient manner. So ACOG recommends hysterectomy with PSO as a definite treatment for adnexal mass and multiple previous conservative surgical procedure in women in whom conservative and medical management has failed. And ESHRE guidelines recommend considering definitive surgery together with the removal of all visible lesions for a woman who completed the reproductive arc and have persistent symptoms despite medical therapy. So again, the NICE guidelines also support that FOGSI guidelines. There is no mention about perimenopausal endometriosis. So the surgery is the first choice treatment, mainly due to the risk of malignancy, but it may carry some risks such as older women when compared with cases of reproductive ages, thus may have comorbidities. These patients may have previous surgeries, accordingly may have higher operative risk. Nevertheless, surgery should be considered and explained and offered to these patients. Similar recommendation has been proposed by SOGC. So the rules out of the following prior to surgery for recurrent endometriosis: we have to rule out irritable bowel syndrome, interstitial cystitis, myofascial and vertebral pathologies. The patient should be warned of potential complication of radical surgery. So it should be individualized and should take into account factors like age, pregnancy intention, cyst features, ovarian reserve, fallopian tube patency, and recurrent status. So coming to the ovarian endometria, one of the most challenging things we have to take a surgery may choose to remove using excision or cystectomy. We have to destroy in situ by vaporization using laser or energy source, coagulate the inner layer of ovarian endometrium using bipolar current, and should destroy it using sclerotherapy. Ovarian endometrioma, clinician should perform cystectomy instead of drainage and coagulation, as cystectomy reduces endometriosis associated pain. So we have to prevent secondary prevention. After cystectomy, the endometrioma in women not immediately seeking conception need to prescribe a combined hormonal contraceptive for secondary prevention of endometrioma. In women operated for endometriosis, clinicians should recommend post-operative LNG-US or combined oral contraceptives at least 18 to 24 months as one of the options for secondary prevention for endometriosis associated dysmenorrhea, but not for non-menstrual pelvic pain or dyspareunia. Performing oophorectomy rather than cystectomy in women with no further pregnancy intention may be advocated in case of high risk recurrence. And CDG recommends the women should be counseled regarding the risk of reduced ovarian function after surgery and the possible loss of the ovary. The decision to proceed with surgery should be considered carefully if a woman has previous ovarian surgery. So surgery for perimenopausal endometriosis is surgery plus long-term suppression, and it is based on the patient's requirement. If there is a unilateral endroma, surgery followed by LNG gives excellent relief. Hysterectomy with or without BSO if family is completed or persistent severe pain, and LUNA and presacral neurotomy effective but creates new long-term problems, not that much effective. So post-operative follow-up, we can either have GnRH analog, COC, Dynagest, LNG, IUS. Persistent endometriosis following surgery, the medical treatment for women with persistent endometriosis following laparoscope, medical treatment might be prepared. Prerequisite is the endometriosis histologically confirmed and malignancy should be ruled out. And recurrence after hysterectomy is around 10%, and reoperation rate after THS without BSO is 85% by 5 years, but no sufficient data of recurrence after tubal ligation. So recurrent endometriosis, the surgery for recurrent endometriosis with the conservative surgical approach has been to be ineffective. So in case of postmenopausal women, there are no data on the benefit or otherwise a conservative approach. So in report of 75 cases of recurrent endometriosis, bowel involvement was reoperated. And so the medical management includes combined COC, norethistidine, dinogest, GnRH agonist, and aromatase inhibitors. So CDG recommends the women with pain for rectovaginal endometriosis refractory to the other medical or surgical treatment. Clinician can consider prescribing aromatase inhibitor in combination with oral contraceptive pill or progestogen or GnRH analog as they reduce endometriosis associated pain. So treatment of severe postmenopausal with aromatase, lot of things. There is a study shows the size of the mass strikingly reduced at the end of 6 months of therapy. So coming to the deep endometriosis, CDG recommends that clinicians refer the women with suspected or deep endometriosis to a center where there is an expertization and a multidisciplinary approach will be better. Performing surgical removal of deep endometriosis reduces endometriosis associated pain and improves quality of life. So the hysterectomy, the CDG recommends that clinician consider hysterectomy with the removal of ovaries and all visible endometriosis lesion in women who had completed the family and failed to respond to more conservative treatments. Women should be informed that hysterectomy will not necessarily cure the symptoms or the disease. They need to be under surveillance. So a word about the tamoxifen. It is not clear whether the tamoxifen induces or promotes endometriosis. Considering the effect of tamoxifen on endometrial tissue as well as the case reports up to date, it may be concluded that tamoxifen use in postmenopausal women breast cancer might increase the risk of endometriosis. So the hormone replacement, when we look at the risk and the benefit, there is a lot of benefit. We shouldn't deny this HRT endometriosis patient. And there is other benefits also, like it can improve the osteoporosis and prevent dementia. So CDG recommends that clinicians continue to treat women with history of endometriosis after surgical menopause with combined estrogen progesterone or tibolone at least the age of natural menopause. They should be put on progesterone, estrogen progesterone combination to prevent reactivation or recurrence. So there is a lot of studies which shows there is no malignant transformation was found after MHT and it is always safe. So coming to the perimenopausal endometriosis and malignancy, the risk of malignant transformation is at least 2.5 and the prevalence of endometriosis varies with the different types of ovarian cancer. Like serous, it is only 4.5, mucinous is 1.5, and clear cell it is 3.5, and endometrioid type is 3.5. The endometriosis is usually not associated with high-grade serous tumors or mucinous type of tumors. So the explanation for the perceived link between endometriosis and malignancy is certain proportion of cases of endometriosis may be a pre-malignant lesion. That is de novo, they may have a pre-malignant nature. And other environmental, endocrinological, epigenetic, genetic factors may be the etiological for both endometriosis and some malignancy type. So endometriosis may be a metaplastic component of the malignant transformation. So endometriotic carcinoma of ovary and endometriosis, there is an association in postmenopausal. They have reviewed 42 patients with endometrioid ovarian carcinoma and found that ovarian endometriosis was present in 11 cases. So they have suggested ovarian endometriosis has a potential of malignant transformation in postmenopausal women. Thus, if found, should be surgically removed. So the same thing the CDC recommends, and it can coexist with other cancers like Hodgkin's lymphoma and perimenopause endometriosis. They appear to have likely to experience early menopause, and psychosocial impact of endometriosis may be severe in perimenopause endometriosis. So the management of endometriosis in the women approaching the end of reproductive life requires special attention due to the potential for recurrence and transformation into malignancy. So the last is, apart from surgical, is the first line of treatment, post-op medical management, lifestyle modification also is important. We should address to that because it is a chronic condition and an anti-inflammatory process is going on. So the diet should be told, the stress management, which will reduce the exacerbate of pain, regular exercise also, they can reduce the pain, and adequate sleep is essential for hormonal regulation. So the endometriosis is not only a disease of reproductive age, but can happen perimenopause also. We have to suspect perimenopausal endometriosis when symptoms appear in already known cases or new symptoms appear in perimenopausal women. Surgery is indicated when medical management fails, but discuss about the outcome. Conservative surgery is possible in early perimenopause in this era when women need conception through ART. Risk of malignancy is slightly higher in perimenopause age group. So the endometriosis lifelong disorder, I should say, it starts at 20, progress at 30, problematic at 40, supposed to end at 50, malignant risk at 60, needs follow-up forever. So keeping an eye on perimenopausal women and postmenopausal women, when there is a previous history of fibroid, adenomyosis, endometrioma, can pick up peri and postmenopausal endometriosis earlier. So to conclude, challenges are what makes his life interesting. Overcoming them is what makes meaningful. Perimenopause endometriosis presents challenges in diagnosis to determine objective of therapy, avoidance or delay recurrence. By appropriate treatment, we can give them a meaningful life. Thank you for patient listening.
Thank you, ma'am, for an excellent presentation.
Very nice.
In fact, the thought that it is, finishes off by perimenopause or menopause is really not true. And at that stage where you still are looking for HRT, then it becomes more of a dilemma again, whether you give those estrogens or not. So excellent presentation. Thank you so much.
Thank you, madam.
Let's go to the next speaker. Dr. Shairus is here. Can I request the chairperson to please introduce him?
Yeah, I think
Yes,
we're
I'm
going
here.
to hear. Yeah, thank you, Shairus, and privileged to introduce my co-chairperson, Dr. Shairus, who's been the chairperson of the Midlife Managing Committee of FOGSI, chair of the Research Committee of KOFOG, right now the ICOG Governing Council, past joint secretary of Kerala Foundation. Over to you, Shairus. I'm not reading your multiple awards and recognitions, of course. Thank you.
Absolutely not required. Thank you. Shall I share my screen?
Yes, please. Yeah, thank you.
I hope my slides are visible and I'm audible.
Yeah.
Yeah. First of all, thank you so much to Sheila Madam and Pratik sir for this opportunity. Such a pleasure to be amongst such wonderful dignitaries for this ICOG certificate course on endometriosis. Stress and mental health in endometriosis is a little bit out of the box, not often talked about, but definitely a very relevant topic. And I'm glad that I got it amongst the list of topics that were there and the list of speakers that were there. Now, first things first, we do agree, however optimistic we are as clinicians, we do agree that endometriosis is a pretty bad disease. Pain at every menses and pain at every sexual act. It does hurt every girl and woman. When it comes to chronic pelvic pain, it is a worry throughout the month. Knowing that it is a progressive disease doesn't really hit us right as far as our mind is concerned. Knowing that the risk of losing your reproductive organs is high, that hurts. Knowing that your chances of conceiving naturally are very less also hits you badly, knowing that you might need an IVF and the related worries about the hormonal imbalances and the concerns regarding the treatment. Everything put together, it's too bad and so sad a disease. Now, as all of you would agree, stress and mental health problems doesn't hit the patient suffering from endometriosis. Stress affects the clinician who's managing endometriosis also. If you are a relatively inexperienced a surgeon and if you have a case of extensive endometriosis to operate the next day, I'm sure a lot of newbies into this profession are having a sleepless night themselves. Now, everybody around seems to be stressed out, even the children too. If I can borrow a few lines from the song Rangila Re, as they said, chocolate khane mein tension hai, doodh peene mein tension hai, tension, tension, tension. And endometriosis is full of tension because of all the concerns that I just listed out. Now, if you look at endometriosis and stress, it seems to share a bi-directional relationship. Chronic pain causes significant psychological stress, while high stress levels worsens the endometriosis symptoms. Now, stress, as you all know, can trigger hormonal imbalances, which could actually worsen the pain of endometriosis, and hence, managing this vicious cycle is crucial in management of endometriosis. The stress endometriosis connect. The vicious cycle, you know that it has chronic pain, there is infertility, there is general fatigability, and a feeling of not doing well. Those symptoms associated with endometriosis lead on to anxiety, depression, and high stress levels. Conversely, this triggers a fight or flight response through the SMA axis, the sympatho-adrenal medullary axis, creating inflammation, which can actually worsen endometriotic lesions. The physical impact is primarily because of the endometriotic lesions which are there in the pelvis. As you all know, stress disrupts the hypothalamo-pituitary adrenal axis, leading to increased inflammation, which can actually potentially make these endometriotic lesions more severe. Not to forget is the immune system dysfunction. Chronic stress can actually weaken your immune defenses, further promoting the migration as well as the growth of the ectopic endometrial tissue, thereby worsening endometriosis. And there are even studies which are stating that early life stress in our children in their early childhood may actually increase the risk of developing endometriosis later in life. How much is the impact on mental health? If you want to quantify, depressive symptoms were reported in almost 85 plus patients who had endometriosis and who had associated chronic pelvic pain. In comparison, it was pretty much less for those women with asymptomatic endometriosis. So I mean to say that endometriosis, a disease as such, irrespective of whether it creates symptoms or not, can affect mental health. But if it is symptomatic, then the impact is profound. In line with these observations, anxiety and depressive symptoms were diagnosed in almost 85% plus women with pelvic endometriosis. We have enough evidence to prove this. Inflammation affects brain function, getting into the pharmacological and the physiological aspect of it. In endometriosis patients, inflammation plays a very significant role in causing pelvic pain and is a contributing factor to the development of chronic pelvic pain, which is something that you all know. We are worried about the pelvic inflammation and the peripheral inflammation, but there is also this element of neuroinflammation, which is the inflammation that is there within the brain. It can alter neuronal activity both within and outside the brain, thereby contributing to the somatic and psycho-emotional symptoms of depression. They activate the microglia. Microglia are the resident immune cells of the central nervous system, which can even function as an activated macrophages, thereby protecting the brain and the spinal cord. Now, the activation of microglia, particularly in the very crucial regions of the CNS, which is hippocampus primarily, that is what is associated with anxiety and depression. This could even potentially be involved in the emergence of mood-related disorders in these girls and women a bit later on. Does stress induce endometriosis? Whether it primarily induces endometriosis or not is still in doubt. But there are enough animal studies in mice which show that if somebody is exposed to chronic psychogenic stress immediately after induction of endometriosis, that actually can increase the lesion size. It also exacerbated the endometriosis associated generalized hyperalgesia, that is, too much of sensitivity even to mildly painful stimuli. That was through dopamine receptor expression. And this is something interesting. Through the use of beta blockers and beta receptor agonist, there were animal studies which were done to show that it was the beta adrenergic signaling and not the alpha adrenergic signaling, which was the central mediator for all these effects in the acceleration of lesion development, the stress-related effects in the acceleration of lesion development. So they even looked at giving beta blockers to these particular mice and to see whether it could arrest the lesion development. And they were successful in showing that when these mice were put on beta blockade, it either totally avoided or reduced the progression of the increase in size of these endometriotic lesions. So these are things that we can look at for the future. Symptoms itself become stressors, right? We are unfortunately a society which is so obsessed with childbearing. So when endometriosis causes infertility, that itself can actually lead to anxiety and depression. Okay. So these stressors need to be well dealt with, and many a times they are largely uncontrollable, especially the factors that come from the society and the family. Consequently, all the stress likely leads to activation of the hypothalamo-pituitary axis as well as the sympatho-adreno-medullary axis, resulting in increased release of glucocorticoids and catecholamines. They also looked at giving steroids to these particular animals in which these experiments were done and trying to see whether that could actually lead on to control of lesion growth and progression of disease. Now, how to manage the stress? I think first you need to manage endometriosis in whichever way. I think those topics have already been covered, so I will not touch upon that. My job is to look at the management of stress. And I think in a country like India, there's a lot of thought about how yoga, meditation, and deep breathing exercises can actually help in managing stress, right? So that can help regulate the nervous system and lower the stress-induced inflammation. Lifestyle adjustments, including regular and gentle exercise, proper sleep hygiene, very, very important, because lack of sleep has been shown to be one of the important reasons why inflammatory pathologies seems to expand and progress. And a balanced diet are very, very critical in making this happen. Do not underestimate the role of mental health support. They call it therapy these days, especially after the Bollywood and the Hollywood heroines started talking about it. It's ideally called cognitive behavioral therapy. It is not just like the routine counseling. Here, the patient is made to talk and patient provides her own solutions within the circumstances in which she is living in. Okay, so that's why CBT or cognitive behavioral therapy is magic for these women. And we need to have support systems. In this era of advancing technology, as well as so much of use of social media, there are support groups where people with similar kind of complaints share their feelings so that they don't feel isolated. They don't feel that it is the end of the world and it is their own problem. So stress, definitely a big problem, something that has to be dealt with. I think every obstetrician gynecologist across the country dealing with a case of endometriosis, I think you need to not just take care of those endometriomas and deep endometriosis and do those resections. No, your job is not just that. I think you need to be a very, very compassionate human being, because here is that woman or girl sitting right in front of you who's badly affected mentally, and the support and probably the optimistic with a touch of reality, the optimistic talk that you give to these girls and women, I think could be magical. On that note, thank you so much for a very patient listening. It's been a pleasure to be here today.
Thank you, Dr. Shaijas. And let me express my gratitude to all the speakers of this session. We've had
Very
some
nice.
fantastic talks by all the speakers, Dr. Kanti Bansal, Dr. Chipa, Dr. Pradeep Kumar Mehta, and now Dr. Shaijas. Thanks very much to our chairpersons for the session, Dr. Arun Arora
Thank you.
and Dr. Sita Pal, who did the honors right from the beginning to the end. We missed out on the other chairpersons, and we will now proceed with the panel discussion, which is going to be the icing on the cake. Can I invite the moderators for the panel, Dr. Mala Raj and Dr. Asha Bakshi, for these guys? Is Dr. Mala there?
Yeah. Good evening, everybody. Asha
Please go
madam.
ahead.
Yeah. Asha madam, good evening. Madam is
Good
going to
evening.
start.
Good
Madam will
evening.
start. Yeah.
So we are running late, requesting you to please finish in half
Madam,
an hour because we have a post test also, which will be conducted later. Requesting
Madam
all
will
the
share.
panelists to start their audio.
Good evening, Asha and Mala.
Good
Yeah.
evening. Can you see my slides?
Yes, ma'am. Can you please go full screen? Perfect.
So, a very good evening. And today I'm going to moderate the panel on endometriosis and infertility. And my co-moderator is Dr. Mala Raj. And the panelists are Dr. Umayal, Dr. Jyoti Budi, Dr. Divya Shri, Dr. Lakshmi Charumila, Dr. Venugopal, Dr. Kundavi, Dr. Kavita Gautam, and Dr. Anshu Basil. And because the time allotted is only 30 minutes, so it's really difficult to do a panel. So we'll try to do short and crisp answers rather than going in detail. We all know endometriosis and infertility does have some association, and that we can see that 25 to 50% of infertile women have endometriosis, 30 to 50% of women with endometriosis are infertile, and prevalence of endometriosis is 6 to 21 times higher in an infertile as opposed to fertile women. So my first question is to Dr. Umayal. Why does endometriosis cause infertility? Dr. Umayal, are you there? May I ask to Dr. Jyoti Budi, is she there? Hello.
Yeah, Jyoti ma'am is not joined yet, ma'am.
And Divya Shri, Dr. Divya Shri.
Can I take the question?
Yes, Kavita. Yes, thank you.
So endometriosis causes a lot of immunomodulatory effect, and there is a lot of anatomical changes which happens due to adhesion formation, and there are a lot of genetic and epigenetic changes also which can trigger the endometriosis. In turn, it can cause, reflect as infertility. So both immunological and also the anatomical disruption which happens causes infertility.
Yeah, so there are many causes. So in short, we can say that there are inflammatory causes and mechanical causes, and both together lead to endometriosis. So how would you diagnose endometriosis? Anybody, any volunteer?
I can take that. So, is somebody else talking?
Yes, Anshu, go ahead.
I think someone's mic is on. Okay. So, the first and foremost is, of course, symptoms and history, painful periods, or painful intercourse that will be there. Then the first that we have is our ultrasound, transvaginal ultrasound, which has now become advanced. We're able to pick up even cases of ureteric and bowel endometriosis that can exist separately from ovarian endometriosis as well, although that is the most common. We can easily picked up feature of endometriosis, but we now know that endometriosis can exist even without ovarian one. So history, a basic transvaginal ultrasound, that will be the main modality for diagnosing endometriosis.
So any comments from by the experts, Kunju Moitin, Dr. Sundar? Are you there? Dr.
Yeah.
Kunju Moitin, Dr.
Yeah.
Sundar? Yeah.
Good evening, ma'am.
Yeah.
I'm here.
Good evening.
So,
yeah,
nowadays the MRI also is very much important in diagnosis, because recently we had 2 cases of endometrioid carcinoma in recurrent endometriosis patients. So always to look for the lymphadenopathy or any other additional lesions, it will be good enough to look for the MRI also. And MRI also is really good in diagnosing the deep infiltrating endometriosis. So it is really good in diagnosing the situation.
Right. So we can use transvaginal sonography, which is very, very easy. And these days, most of us do have 3D ultrasound, and we are getting more expert because we are a better person, because we are seeing the patient through the ultrasound, and at the same time, we may be doing laparoscopy, and we can correlate the lesions. So I think that is the best thing. But of course, MRI will help us again establishing the diagnosis. But the man behind the MRI who reads the MRI is very important again, and we should also ourselves be able to read the MRI. So these things are very important, and every gynecologist who is practicing infertility should be well versed with transvaginal sonography. Now, next, I will request Dr. Mala to take over.
Yeah.
Mala?
Yeah, thank you so much. Yeah, thank you so much, ma'am. Yeah, thank you so much, madam. In continuation with the diagnosis part of endometriosis, I would like to know whether there are any blood markers that you will look at for diagnosing endometriosis apart from the imaging modalities. So can Dr. Kundavi take this?
Yeah, thanks, Mala. I think people do CA125, but they are not useful for diagnosis because it can be raised in other so many other conditions too. But it can be used to monitor the progress of the disease. The other new markers, I think, though it is not proven, people use microRNA, circular RNA, cytokine levels have been taken, and people even talk about the menstrual biopsies when taken in the luteal phase, like BCL6 testings and other things.
Yeah, so very well said. So CA125 is definitely not specific, but how do you think this BCL6 will help us to come to a conclusion, like based on these values, like how do you think we can either identify endometriosis, or it is kind of used for screening endometriosis?
So this is BCL is a beta cell lymphoma 6, where you take a biopsy around 7 to 10 days post ovulatory, and you look for the scores, the high scores of 0 to 4. And if you have a score of more than 1.4, that it can rule out a silent endometriosis, especially when you have a woman with a recurrent IVF failures or an unexplained infertility. You can still prove by these values, by taking a biopsy, and these levels can prove that patient has got a silent endometriosis. So probably such patients, they may benefit from a diagnostic laparoscopy and proceed, or a medical management.
Yeah. So is there any role for diagnostic laparoscopy in the current scenario to diagnose endometriosis?
I think yes, if you have an unexplained infertility, if the patient has got pain, and you don't have any other answers, a laparoscopy, yes, it is not a diagnostic lab. I think laparoscopy and proceed. And this is you see and treat.
Yeah, that is a point. There is no role for diagnostic laparoscopy. Laparoscopy has to be always operative. So you cannot just put a scope and diagnose endometriosis, because we have other modalities by which we are able to diagnose. If you're putting a laparoscope, you have to do a complete operative procedure where we need to excise the lesions. So that is a take-home message from this particular aspect. But if a woman has an endometrioma or an endometriosis, do you really operate on these endometriomas, and when do you exactly operate? Can I ask someone else to take over, please? Is Dr. Venugopal there? Or Dr. Lakshmi is there? Lakshmi, can you please take this?
Endometrioma as such doesn't indicate for a surgery, but if she has associated pain, then definitely we should go ahead. Otherwise, if it is coming in the way of the oocyte aspiration, if the candidate is going for IVF, then also we recommend endometrioma excision before IVF. But otherwise, just on seeing an endometrioma, we shouldn't be going routinely for a cystectomy in these patients.
So is there any particular size cutoff
I
beyond?
think the RCOG recommends 4 centimeter and above to be taken for a surgery, but we also need to look at whether any other structures of the pelvis are involved.
Okay, so other parameters do you will take into consideration about the age of the patient, the AMH? Will you with if the endometrioma is 4 centimeters, and if her AMH is very low and she is more than 35, what do you do? Like, you still take her up for surgery, or you will directly jump into ART procedures?
Well, it also depends on the antral follicle count along with the AMH. If I see that I can get a good result with doing an ovulation IVF stimulation, and we can get a decent number of follicles, then we would rather prefer doing a pickup prior to doing an endometriosis surgery or the removing the endometrioma, because even with surgery, there is a chance that her AMH will fall further after removing the endometrioma.
So I think we should take opinion from the expert now.
Yes, ma'am.
On endometrioma.
Yeah. So, yeah, can I proceed, ma'am, with this one? So, can
Is there any
Yeah, see, yeah,
Dr. Sundar?
yeah, madam, I would like to have my opinion on this, because endometriosis with infertility or endometrioma with infertility, the size doesn't matter. There is no indication for surgery unless the patient is having severe pain. Even in the present scenario, if the patient is having pain also, you can control the pain with the Dynogest. And because it is an era of PPS also available, you can continue Dynogest, do stimulation, and pick the oocytes and make embryos. And if the patient, after picking the embryos, you can consider surgery if there is pain due to severe deep infiltrating endometriosis. Otherwise, the size of the cyst is not a criteria at all, unless otherwise cyst obstructs your oocyte
I think this is a very important take-home message. Correct.
Dr. Asha, what about the sclerotherapy? People are talking about laparoscopy followed by sclerotherapy or an ultrasound guided sclerotherapy when you have an endometriotic cyst of 4 to 5 centimeters with low AMH.
Yeah, it's a sclerotherapy. In fact, it is still on the trial stage. They have lots of limitations. You cannot use it for multiple endometrioma. It has to be a single endometrioma, and if they are having multiple, septum, then sclerotherapy is not going to work, because it has to be a organized endometrioma where the sclerotherapy agent can be instilled and then removed. And also there are lots of pitfalls with sclerotherapy, like bowel necrosis and other things. So that's why it has not taken up very well.
And the thing is, why to touch endometrioma? If you can really access the follicles, you can do a good retrieval, then why unnecessary touch the endometrioma? I think this is the most important message, that size does not matter. It matters only if it is coming in the way of oocyte retrieval, if there is a lot of pain, or you are suspecting something else like a malignancy. And sometimes you may come across accidental finding of endometriosis associated malignancy, and these are the cases you have to keep in mind. And it has been found that there is 3 to 4 times increase in incidence in clear cell carcinoma and endometrioid carcinoma. So very important to always keep that in mind.
What we have seen is, like, when we have her elevated CA125 recurrent endometriomas, where you had a previous history of mucinous cyst adenoma as a histopathology, we found such patients tend to be having a clear cell carcinomas on the higher rise. The last 20 years, we have had 3 patients on that.
Yeah, so I think this is one thing we have to keep in mind. Though we are saying touch me not, but sometimes you may have to touch, and you have to keep in mind that sometimes there may be an associated malignancy.
So the basic advantage itself is only for biopsy, and also sometimes the environment also improves once we remove all these endometriotic lesions. Sometimes they are also able to conceive naturally. So the anatomical distortion, all that gets corrected. So we can also give that as an advantage to the patient, provided her AMH is very good.
True.
So, so can someone highlight, can we go ahead with the surgery part a little more? So like how the surgeon here, Anshu is the surgeon here, right? Lap surgeon. Can you highlight like how exactly you would be doing a laparoscopic cystectomy for these particular patients, because these are going to be a fertility enhancing procedure. So any particular techniques that you would follow?
So, it has to be started with a preoperative planning. There is a proper mapping of the endometriosis, because a lot of the time there is associated adhesion, involvement of the ureter, bowel, bladder. That entire thing has to be mapped before surgery. The principle is again good surgical dissection, minimal use of electrocautery, and a cystectomy would be a complete cystectomy rather than ablation of the lesion. That would be the main principle here, and removal of all visible endometriotic lesions without compromising the integrity of the structures. That is the main principle.
Yeah, so there is no rule for just drainage. It has to
To
be
do
a severe
cystectomy, complete cystectomy,
and
yes.
also try to use vasopressin so that you can secure hemostasis
Yeah.
without any kind of an energy source. Okay. So, madam, you want to take over? Asha, ma'am?
Yeah, anyone wants to talk about deep infiltrating endometriosis and pre-IVF surgery?
I think deep endometriosis only when the patient has got pain or the patient's preference, you can go ahead with the surgery. Otherwise, IVF could be an option. But again, you'll have to talk about the risk and the benefits over the ART treatment and the surgery. And you need to have an expert to do the surgery for deep endometriosis. And there is always not much of recurrence because it might involve the ureters and other organs as well.
Anyone would like to talk on endometriosis fertility index when you do laparoscopy?
Dr. Lakshmi, is there? Dr.
Yeah,
Lakshmi?
I'm there, but I'm not into surgery.
Yeah.
So if anyone does it, please.
I think it's a validated scoring from 0 to 10 because, and you have various factors like patient age, the previous surgeries, previous pregnancies, and you have a least functional score of tubes, ovaries, and the fibria has been taken care. And if you have a score of 0 to 3, it really tells you the probability of having spontaneous conception. So it just helps you to counsel the patient for a spontaneous conception. So depending on the score, probably if you have 0 to 3, the probability is only about 10% of having a patient with spontaneous conception. If it is more than 6, then you can tell them, yes, you can go wait for a normal conception. But if the score is less, you can tell the patient, it helps you to counsel saying that you can directly go for IVF. So it really helps you in that situation. And people feel that it is much superior than the revised AFS score.
Yeah, so it's a very important scoring system that we need to do while doing a laparoscopy for all these infertile patients because not only just for our idea, but it also helps us to counsel the patient as Dr. Kudavi has rightly said. Okay, so good scores, good outcome, low scores, poor outcome. So we need to modify our treatment protocol. So of course, deep infiltrate endometriosis, there are various literatures which have come up now that surgery is a very good choice because most of the time once you remove these endometriotic lesions, of course it has to be done by the expert and with also multidisciplinary approach is needed. These endometriotic lesions keep the environment very clean and as a result the quality improves and sometimes the disharmony, marital disharmony which exists because of the dyspareunia, all that also gets corrected and they are able to get pregnant naturally. So that is the only thing, and also it has been found that it improves the outcome of IVF also. So expert opinion,
So
please.
Mala is an expert in the expert surgeon. So she will always talk about in favor of laparoscopic surgery for deep infiltrating endometriosis. Otherwise, people would just directly go for ART, IVF. Yeah. So now next is medical management recommended for management of infertility due to endometriosis?
No.
No.
There is
Not
severe
Kavita, yes, Kavita.
Yeah, if there is time taken between the surgery and the IVF, probably a medical management would be put in place. But if we are doing a surgery and immediately taking up the patient for
Yeah, that's not.
fertility management, I don't think there is a need for suppression.
Yeah, but the medical
overall,
treatment,
yeah.
can I say something?
Yes,
Yeah, because very often because we don't do the fresh transfer very often in these cases. So after the pickup, creating the embryos, you can suppress the endometriosis by giving the GnRH agonist depot, then do the frozen transfer so that the inflammations, all those effects of the high estrogen what has been created during the stimulation can get rid of. So that is one role of medical intervention during the in between the pickup and transfer.
Yeah, so that is very, very good. In fact, after you create the embryos, then we can suppress the endometriosis because it also improves the endometrial receptivity. So I think before embryo transfer, we can give it and then probably do the transfer. And that seems to be really giving them a lot of relief. Yeah.
Yeah. Any experience, anyone has an experience on use of GnRH antagonist as pre-treatment? Because there is this particular study where they have given GnRH antagonist for 8 weeks prior to IVF and the results are still awaited. Has anyone tried this? or anyone would like to talk on this?
Ma'am, not because of the egolics, but people have tried the Dynogist and then they continued, instead of giving a withdrawal period, they said that you can go ahead with the progesterone primed ovarian stimulation with, and studies approved, they have a good number of oocytes and the good quality embryos as well.
Probably recently we are using the oral antagonist for adenomyosis and endometriosis, but I don't think there is any proven.
But the oral antagonist is not approved for IVF per se. It is for the pain with the adenomyosis.
Yeah. As such, it is under the research rather than there aren't any guidelines that we can use it. But this particular study I thought was interesting, so I'll put it. What about IUI? Does anyone do IUI for patients with endometriosis, or IUI is no?
Stage 1 and 2, probably yes. The stimulated IUI would give a better results, maximum 3 cycles, not more than that.
If stage
still there is a
Patent tubes are necessary.
no addition,
Tube should be open, and then there is no scar tissue, and then we can try. And
Yeah.
also duration of the infertility and age of the woman is also important before we go for this.
Sure.
Especially if the woman is young, we can go for it.
How many IUIs you will try for these ladies?
It's again, Dr. Lakshmi said, no, age, the AMH, the duration, and plus if stage 1 and 2, not more than that, I think you can go ahead. 3 cycles.
Yeah, 3 cycles should be okay.
Yeah, endometriosis also affect the sperm quality, not only the oocyte quality, especially the deep infiltrating endometriosis. So I think we should not waste too much of our time in IUI also. So when do you think the women will be moved to IVF?
I think it depends upon the age, the AMH, duration of infertility. If the male partner has got a problem, is a male infertility, and stage 3 and 4, I think you should go ahead with IVF.
Okay, so and also when you have a very poor EFI scoring.
Yeah.
When you know for sure that she's not going to conceive even with an IUI. Okay. So yeah. So what would be the best protocol that you would advise her for an IVF procedure?
I think the literature says there is not much of benefit between antagon and agonist. I think most of us are used to the antagon protocol because when you give an agonist protocol, they need a larger doses of gonadotrophins and longer duration is required. So, and not much of difference between the number of oocytes collected. So, as Dr. Kunjumoidin said, you do an egg collection using an antagon protocol, freeze the embryos, give them an agonist protocol, though again it's a controversy because earlier we all thought it does improve the endometrial receptivity. Now people say there is not much of benefit with the ultra-long protocol. So I think we would go with an antagon protocol. And progesterone primed, if you feel that you are going to freeze those embryos, you can go ahead.
Okay. Right. So, do you always do a frozen embryo transfer, or you can also think about fresh transfer in these patients?
The literature says you can go ahead with fresh or a frozen, I think, but if you ask me, I would go with the frozen cycle because I would suppress them and then take them for a transfer.
I think the endometrial preparation receptivity is much better when it is in frozen embryo transfer, especially endometriosis patients. I would also prefer downregulated frozen embryo transfer.
Anybody would do a pre-IVF hysteroscopy for these patients?
Can I add something with regard to the protocol?
Yeah, please.
Yes.
Yeah,
Yes.
because now there is this fresh long protocol plus fresh transfer. It is coming up largely because mainly in case of endometriosis, if you suppress properly, then stimulate, take the oocytes out, and can do the blastocyst to fresh transfer because there is a thought of, because once when we do antagonist protocol, taking the oocytes out to freeze the embryos, then suppress, then at the time of endometrial preparation, if you give estrogen again, the disease and pain can come back. So that time, usually the natural cycle FETs may not work because of the suppression effect of the agonist. So there is a thought of this agonist, long agonist protocol and fresh transfer is coming back. Thank you.
Okay. That's a good one. So any role for pre-IVF hysteroscopy? Is it routinely done?
I think we would do it because your trial transfer sometimes may be difficult with the endometriosis. So we would make sure that the cavity is fine because you can anticipate difficult transfers.
Endoscopy is generally done, otherwise it's not specifically done for endometriosis per se.
Yeah, but basically, I feel for all these endometriosis, adenomyosis patient, it is always better to do a hysteroscopy and assess the cavity, because many times we see that the endometrium itself will have so much of lesions. Because of the hyperestrogenic conditions, you can pick up many polyps, you can see hyperplastic endometrium, and all these little adenomyotic changes, all those things, it will give us a good opportunity to rectify all these problems. And more so, because of this deep infiltrating endometriosis, if you see, the cervical canal also would be angulated. So you may
Yeah, the
find
orientation.
embryo transfer would be very difficult. So I generally, when it is an endometriosis, I feel it has to be done so that we will correct everything and then we'll have a smooth transfer rather than directly subjecting them for an embryo transfer.
Again, it is a very individualized approach, I would say. If you have done a good mock trial and if the transfer is easy and she doesn't have severe endometriosis or severe adenomyosis, I don't see any reason for doing hysteroscopy. But maybe in a way, probably Mala, you may be correct, because we have seen that there is in association of chronic endometritis with adenomyosis. So maybe if you want to rule out that, then it can be used. But at the moment, the consensus is not for routine hysteroscopy before every IVF for endometriosis. So this is an interesting paper. I thought I'll just mention. This is an Indian paper where they've shown the benefit of various protocols and results that ICSI is better than IVF and all the. So that it is very nice to have some Indian papers. So that's the reason I've shown this paper. Now discussion about fertility preservation, because we don't have much time. Anybody?
Probably if you have a patient who has a bilateral recurrent or an extensive ovarian disease, you should start talking to the patient the risk over the benefit of fertility preservation. Young women with an extensive ovarian disease, a good AMH, I think you should talk to them. At the same time, an elderly woman who has got a recurrent surgeries and who wants to delay her childbearing, again, she's another potential candidate for fertility preservation. But at the same time, you need to counsel about the number of eggs, what we are going to collect.
And
Yes, I
also
think it's very
maybe
important to
carcinoma
be
patients as
sensitized.
well.
Yeah.
In
Because what happens is that young girls come to you with severe endometriosis. You are going to operate her. And these are the patients who are going to have problem in future. So always, and now people are getting more open about egg freezing. So I think it's high time we start counseling our patients when the situation is appropriate. Yes, Mala.
Yeah, so
Mala.
yeah. So do you think there is a chance for the endometriosis to flare up during IVF treatment, or any kind of a recurrence that could occur after the treatment IVF?
The answer is no, but I think you'll have to take a call. You have to keep a very close because they need a long-term management. But there are no recurrences as such by the treatment.
not because of IVF, no.
Yeah, okay. So yes,
short lasting, so
yeah, but the literature say that there is no recurrence following IVF treatment. Also, we can very broadly, start with IVF. How about the pregnancy and the outcome? So, yes, the women conceiving after endometriosis or with endometriosis, what are the complications that you can anticipate?
We have seen the placental ratios, like placental low lying is very common. Miscarriage and ectopic pregnancies we have seen.
And also,
yeah, preterm births as well.
Perclita, if they have adenomyosis associated.
Yeah.
Then that is also.
I think the message to the delegates is single embryo transfer is an ideal one in a case of endometriosis.
Yeah, so they can have lot of
Otherwise also, whenever possible, single embryo transfer.
Yes, ma'am.
So if you have done an adenomyosis surgery, if you have done an adenomyomectomy, then for sure it has to be a single embryo transfer, and it has to be after 6 months after surgery. So pregnancy as such is also not going to be very smooth. So we need to be anticipate quite a lot of problems, and then make sure that it is untoward. So these are the few things on pregnancy. Then
And this is a
immunotherapy.
futuristic approach about immunotherapy in endometriosis.
I think that's
I think
it's coming in a big way.
yeah.
People are talking about the use of thymosin in endometriosis, and because it just acts at the Th1 and Th2 as well as because it's an inflammatory pathology, so increase in ROS, and so people might benefit, but not much of experience on those things.
Yeah.
Okay. So yeah. So anything else apart from these thing, any adjuvants that you believe in giving these women apart from our regular treatment protocols? Do they really help, the adjuvants?
I think people talk about a lot of lifestyle stress related, as Dr.
Yeah.
Sai just spoke about it, and acupuncture and all those stuff could probably improve their.
Yeah, maybe a lot of things and reduce caffeine and inflammatories. This endo diet is really something that's very popular and going on these days, but I've not really had so much experience with these.
And
So
being careful about the use of plastics, I think that is also coming in a big
the
way.
role of microbiota. So all those things, I think, as an adjuvant, we have to,
The
give
probiotics, yes.
Yeah, that's it. Yes.
to correct
So
all those.
lifestyle modification is important everywhere, and so it is important in endometriosis also, and especially the role of exercise. It is very, very important. And once the pregnancy occurs, then people think that pregnancy is a cure for endometriosis. So we have to
That's true.
explain to them that it is just a temporary symptom improvement, and long-term hormonal suppression still may be required. And we have to discuss about pain and recurrence risk. So basically, I think
Actually, in pregnancy, the endometrioma looks different. So the expert should be there to differentiate between corpus luteum and the endometrioma as well.
Yeah. So I think in the end, we would like to conclude. Mala, would you like to conclude?
Yeah, so ideally speaking, endometriosis with infertility is basically a double challenge. So we need to make sure that we take all the adequate precautions and make sure that she achieves a pregnancy. And even when she achieves a pregnancy, we have to make all the efforts for her to sail through smoothly. So we have an expert panel to take us through with all these points, and then and it was very well discussed. So thank you so much. And yeah, Asha ma'am, you can also sum up.
Yeah, so I think it has been a very interesting panel, though we had the time was less, but overall it was very interesting. And at the end, I would like to thank you all and invite you all to the Vice President Conference, which is to be held in Indore. It is a conglomeration of all the 5 vice presidents, and it's only one conference this year, and it is in Indore on 8th, 9th, and 10th of May. So please save the date and please attend it in large numbers and enjoy the hospitality from Indore. So thank you very much. And thanks to all the panelists who actively participated, and Mala.
Yeah, thank you so much, Asha ma'am. And thank you so much, Dr. Kunju Mohiddin, and all our expert panelists. Thank you.
Thank you, ma'am. Thank you so much for making us a part. Thank you.
Thank you. Thank you so much.
So I'm not sure if Dr. Ramani is there. Thank you, everybody, for all your hard work and coordination behind the scenes. Can I request the back
Sir,
end
I
team?
am very well here, sir.
Yes, sir.
Yes, ma'am.
Yeah. So let us go for the posters. Everybody is posting. Yeah,
Correct. Shreya and back end team, can you please post the link?
Yes, sir.
Start the timer, please. We are already late. So the link is posted and you have 15 minutes exactly to complete the post test. As already explained, you need to have 50% marks on each of the 3 days for you to be able to receive the certificate. We had nearly 650 simultaneous viewers, and we have more than 1,200 registrations for this first ever ICOG certificate course in Dr. Sheila Mani's tenure. Thank you, all of you, for being there. And I'll stop speaking because I'm sure it's disturbing you while you're doing the post test.
Many are asking, they are not able to open the link. Pratik.
Can't have this kind of symptom that people coming. How many?
It works fine for me, ma'am.
They are not able to open, many are saying.
I'm able to open it and it works absolutely fine. Maybe they need to log in from their laptop and not from their phone. If you're logged in into your Gmail or Google ID, the test will work fine. It's worked on the phone for Rashmi as well. Hi Rashmi, thank you for coming.
Okay, thank you. Dr. Ramani?
Yeah.
Thank you. Okay.
Okay. Thank you, madam. Thank you.
I have to leave for another program. Okay.
Okay. Yeah.
Yeah, thank you very much. I think it was very good at the end. Still, we have more than 500 people.
Yeah.
Yeah, so that
To
is
begin
very
with, it
good.
was around 650, beyond 650.
Yeah, very good attendance.
Thank you, ma'am. We'll see you tomorrow then.
Yeah, okay.
Okay.
Bye.
Thank you.
It's over, no?
Yeah.
The test also? Yeah,
We
thank
have
you.
6 minutes, and usually after the test is done, then the convener will announce the answers.
So Dr. Ramani will wait for some time?
Yeah, I
She'll
am
wait
here,
for about
madam.
6 minutes.
Okay, fine.
She'll
I will
announce the
leave because
answers
I
and
have
then
to
we'll
join for
close.
another scientific program.
All right. Okay. Bye.
Okay, thank you. Thank you all.
Thank you, ma'am. Bye.
The time over?
Still 3 minutes to go, ma'am.
Okay.
I think the time is up.
Yeah.
You can go ahead and go through the MCQs and the answers, ma'am.
Okay. What is the incidence of endometriosis? The correct answer is C, 7 to 10%. Why does endometriosis occur? Retrograde menstruation, implantation theory, stem cell, all of the above is the correct answer. Probable etiology of scar endometriosis or immunological theory, mechanical transplantation, stem cell theory, and retrograde. Mechanical transplantation is the correct answer. Indication for surgery in adolescent endometriosis, all of the following except asymptomatic endometrioma, ruptured endometrioma, Mullerian anomaly with endometriosis, doubtful diagnosis. The answer is asymptomatic endometrioma. Rectovaginal endometriosis, it shows red Indian headdress sign, question mark sign, ground glass appearance, Venetian blood sign. So the correct answer is A. Commonly affected age group, less than 20, 20 to 30, 30 to 40, greater than 40. It is about 20 to 30 years. Ideal drug for management of adolescent endometriosis is GnRH analog, OCP, Dynagest, all of the above. Dynagest. It's an ideal drug. Then GnRH agonist can be used for medical management of endometriosis in adolescent for patients with pain after surgery if there is residual endo, grade 3 and 4 endometriosis before ART. I think all of the answer above. And the following is true regarding elagolix except oral GnRH antagonist, short-acting GnRH antagonist requires add-back therapy. Low doses does not suppress the what is true except, that is, requires add-back therapy. Then the future treatment of endometriosis includes statins, infliximab, and pentoxifylline, and all of the above. Answer is all of the above. Do you think sporadic awareness is enough for earliest detection? No. Do you think the teamwork is necessary in this context? Yes. And then the 13th question, which clinician must know about endometriosis, whether the gynecologists or the GPs? Answer is GP. Endometriosis end after pregnancy, after menopause, after hysterectomy for endometriosis, and none of the above. Answer is none of the above. Goal in treatment includes alleviates pain, reduces recurrence to improve quality of life. Answer is all of the above. After hysterectomy for endometriosis, to prevent surgical menopause, estrogen to be given, only progesterone should be given, estrogen and progesterone to be given, and none of the above. So the answer is estrogen plus progesterone to be given. CA125 has got the highest sensitivity in minimal endometriosis, superficial, deep infiltrative, and stage 3 to 4. Answer is stage 3 to 4. And which cytokine is most commonly, consistently elevated in serum peritoneal fluid in women with endometriosis? Interleukin 2, interleukin 6, interleukin 4, and interleukin 10. Interleukin 6. And overexpression of BCL6 in utopic endometrium is associated with increased ovulation, progesterone resistant, hyperestrogenism, and tubal blockage. It is progesterone resistant. Compared to CA125, specific miRNAs may offer improved reduction in stage 4, early stage 1 and 2, postmenopausal women, tuberculosis. It is early stage 1 and 2. So thank you all the participants in this quiz program. Thank you. Thank you so much. In this
Thank you, everybody, all of the wonderful faculty, our convener, Dr. Ramani Devi, and our two conveners and coordinators as well, who have done a fantastic job coordinating from the back end. Thank you also to Shreya, Nilima, Poonam, all the back end team for all your hard work. And for those of you who logged in, we will see you again tomorrow at 4 o'clock for the day 2 proceedings. Until then, goodbye, God bless, and bye.
Thank you so much. Good night, everyone.
Thank you, ma'am. Bye.